One, please start, sir.
Hello, good evening, everyone. And it's a great pleasure to welcome you all for the day 2 of breast cancer update. And it's a pleasure to welcome and invite the organizing secretary, Dr. Nikhil Ghadyalpatil, a senior consultant medical and hemato-oncologist at Yashoda Hospital, Hyderabad. Hello, good evening, Dr. Nikhil sir. It's a pleasure to welcome you. We request you to start the sessions with your opening remarks, please.
Thank you, Mr. Mathur. It has been a wonderful yesterday's sessions, what we could all witness. Yesterday, we definitely discussed a lot about radiation advances, some of the medical oncology advances, and of course, the surgical advances in the breast cancer management. Day 2 is equally exciting when we talk about the kind of abstracts what we are looking at. We are also going to witness quite an interesting debate. That is something is going to be the highlight of today's evening. And we have some of the very renowned oncology friends with us. And it is like, we often don't see all these stalwarts coming together for one meeting. So we are extremely privileged to have all of them. And today's topics again will be spaced majority on medical oncology as well as radiation as well as bit of on surgical oncology. Again, a brief announcements about today's sessions. Again, requesting all the faculty members to stick to their time. I also request if at all any questions are there from the delegates or faculty to paste in the chat box, something if we can take it during our moderation times. And try to stick to the time because we have got quite a long session today. So with this, I kind of start day 2 of the meeting, and we have the first we'll present some of the abstracts, and subsequently we go on to the moderation as well as panel discussion. So with this, I request Dr. Firoz to take over the first session. Dr. Firoz is surgical oncologist at COI, and he's going to deliver his abstract, first abstract today. Can we start, Dr. Firoz?
Yeah. Can I have to share my screen?
Yeah, absolutely.
Is it visible there?
We can't see the slides for sure. I think you need to open the presentation.
Yes, I have opened mine. It is showing as your screen sharing.
Yeah, we can see you, sir. We can see
you need to open your presentation first, then you can share your screen.
Yes, I have opened.
So if you can permit, we can share your slides, and you have to say.
Yeah, I think you can do that.
So, Dr. Firoz, sir, please start. Yeah, okay.
Yes.
So you just have to say slide next, slide next.
Yes. Okay. Okay, thank you for inviting me. Good evening, everybody. And I'll be speaking on an Italian multicentric trial, which was presented last year at the San Antonio conference, and it is about the preservation of axillary lymph nodes in a T1 T2 breast with in whom sentinel node biopsy is done, and the pathology has shown 1 or 2 nodes positive. So this is an Italian trial, multicentric Italian trial, and with more than 50 centers taking part in the trial. Next slide, please. Yes, as you all know, sentinel node biopsy is the preferred method of managing a clinically negative axilla, and it is mainly because of the lesser mobility associated with the procedure. And this trial is a surgical trial, which is a non-inferiority trial, comparing the outcomes after a sentinel node biopsy alone. That is the experimental arm and it is compared with the completion of the axillary node dissection after the sentinel node biopsy. Report has come as 1 to 2 nodes positive. So this trial has been done in tumors less than 5 centimeters, that is T1 and T2, and a clinically negative axilla. So they say that they have assessed the axilla with ultrasound, and that is how they confirm the clinical examination plus an ultrasound. That is the basic requirement for labeling a clinically negative axilla. So basically, it is to see if one needs to complete an axillary dissection if up to 2 sentinel nodes are positive in T1, T2 disease. And this same question was addressed earlier by the C11 trial in 2010, and which has given this a very convincing answer, which many of us follow now. So next slide, please. Yes, but this trial was mentioning regarding the limitations of C11 trial, and they want to correct those limitations and do this trial. So the Z11 trial limitations, which are very commonly mentioned, are mainly the underpowering due to the premature enrollment ceasing of the trial, and there were a large number of patients who were lost to follow-up, and 25% of the patients had only this trial had micromets plus macromets in the nodes taken into consideration, and 25% had only micromets. And so the Z11 trial was looking into a very low risk group of patients. So this, when the Synodot trial was taken into account, they wanted to correct those lacunae or deficiencies with the Z11 trial. And there was a lack of post-op RT control assurance in the Z11 trial, and 20% of the Z11 patients received nodal radiation, which was against the trial protocol. Next slide, please. So this Synodot 1 trial tried to make it a uniform clinical pathological parameters in the trial patient population, and they wanted to do a trial with a longer follow-up and a limited loss to follow-up. So this trial had more than 52 centers, which has got a very good cross-section of treating doctors and patients. Next slide, please. Yes, so this is the methodology of the trial, and this trial included patients only in between the age groups 40 and 75. They ruled out age less than 40 mainly on ethical grounds, because they didn't want to take up those patients with high risk for various poorer prognostic factors. So this was the age group. Then, like I said, patients with tumor size less than 5 centimeters, and the negative preoperative ultrasound was mandatory. And this trial took in patients who underwent either a breast conservation or a mastectomy. So mastectomy included around 25% of patients. Mastectomies included around 25% of the patients. So when this trial was started, they were planning to do a study for around 2,000 patients, but after randomization, the total number of patients came down to 889 only. So we don't know exactly why they stopped the trial at this point. And there were so patients with 1 to 2 sentinel lymph nodes positivity on pathology were randomized. So this is the schema, and the axillary lymph node dissection is the standard care, and the patients who did not undergo axillary node dissection after the sentinel node was the experimental arm. And after this, the patients underwent their routine adjuvant therapies. Next slide, please. So the axillary dissection included removal of at least 10 nodes in level 1 and 2, and adjuvant systemic therapy was guided by tumor biology. Radiation post-op was given as per the standard institutional regimens, and the primary endpoint was overall survival. The secondary endpoints of this trial are local regional RFS and the DFS. Next slide, please. Next slide, please. Yes. So this is the outcome. Out of 443 patients in the standard arm, that is the ALND arm, there were 4 exclusions because of the following reasons. That is, one patient had 3 positive lymph nodes, one patient did not have any sentinel node positive, then one patient with T3 disease, and one patient with M1 disease. Same thing in the experimental arm, there were 6 exclusions. Next slide, please.
Sorry for intervening. You have 1 minute to conclude.
Yes, the trial period was from 2015 April to March 2020, and the median follow-up was around 34 months. Next slide, please. Yes, the results of the trial showed that the median number of lymph nodes which were harvested were around 2, and micrometastasis was present only in 2 patients in the total in the standard arm as well as the experimental arm, and the positive number of positivity in the non-sentinel lymph nodes was around 44%. Next slide, please. Yes, at the median follow-up of 34 months, the number of events happening was around almost same, and there was no statistical difference in the local regional RFS or the distant DFS or the overall survival. Next slide, please. So this is the chart showing there is no difference in the outcome between the 2 arms. Next slide, please. So this is to be compared with the Z11 trial, and these are the various points which were compared, and this trial is just in the infancy. They are still getting the follow-up, and so Z9 has got a follow-up of 9.3 years, and this group has got also mastectomy in the treatment arm. So the luminal type A cancers around 80%, 75% in the Z11 and 81% in the C0 arm, and T2 tumors almost same. Next slide, please. So is this going to be practice changing? Maybe yes. I'm not very sure, because we need to get more data, more follow-up in this trial, because almost 44% of the patients have in the axillary dissection arm had disease in the non-sentinel nodes. We have to have a longer follow-up for the axillary failures. Next slide, please. Yes, the pros of this trial is the multicentric, and hence extrapolation to general population is better. It's got a good sample size and appropriate primary outcome. The cons are the only follow-up of 3 years and standardized procedures to be followed by various groups. We don't know whether they have been strictly adhered to, and the data on radiation is required. Next slide, please. So this is what I think. We might be using this trial for selected groups with a good disease biology. Next slide, please. Thank you.
Thank you so much, sir. Good evening, everyone. Moving on to our second abstract, I invite Dr. Manjula Rao, consultant breast specialist and oncoplastic surgeon, Apollo Proton Cancer Center, Chennai, to deliver her talk. Welcome, ma'am.
Hello, good evening. Am I audible? I'm just going to share my slides.
Yes,
Could you tell me if that's visible as well? Am I audible? Hello?
Yes, ma'am. You're audible, ma'am.
Great, great. So thank you so much for that introduction. Before I begin, may I compliment Dr. Rajan? I really enjoyed your talk. So just as a follow-up of that, I will be presenting the talk that Professor Reshma Jagsy presented as a part of the educational session in the SABCS 2021. Sorry?
You can't see your slides, ma'am.
can't see my slides. Just a second. Now?
Yes, ma'am. Perfect.
Fantastic. Okay. Okay. So this talk was actually presented by Professor Reshma Jagsy, titled "Can Radiotherapy Replace Dissection After a Positive Sentinel Lymph Node Biopsy?" Just a minute, sorry, I'm not able to visualize the screen. Just give me a minute. I sincerely apologize. Yeah. Right. So I apologize for that brief interruption. It is quite ironic that I will be presenting this talk, considering that I am a surgeon, but I am hoping to do my best and present this talk in an unbiased manner. So I will be presenting Professor Jagsy's slides interspersed with a few of my own. Now, why are we even discussing this topic in the first place? Why are we talking about radiotherapy or any other modality replacing an existing modality? So we all know that at the end of breast cancer treatment, it does leave patients, a majority of them, with undesirous complications such as lymphedema, which causes a huge amount of physical, emotional, mental burden and compromises their quality of life. So few of the factors that contribute to the occurrence of lymphedema in breast cancer treatment includes axillary lymph nodal dissection, even just a mastectomy, and radiation to the axilla, etc., amongst other reasons, which is why there have been a lot of efforts that have been made in the past few decades to de-escalate axillary nodal management. So let's take a look at some of the evidence that is available to us in this regard. The concept of de-escalation was first highlighted in the NSABP04 study, the results of which showed that there was no difference in the regional recurrence rates after 25 years in both patients undergoing a radical mastectomy or a total mastectomy with regional nodal irradiation. And this was despite the fact that there was a substantial incidence of positive nodes in patients with clinical node negative axillae. And after this, of course, came the concept of breast conservation surgery. Then we moved to sentinel lymph node biopsy. So you can see that trend moving towards de-escalation of treatments. And then we had the results of the ACOSOG Z11 study, which shook things up, wherein 891 patients with early breast cancer undergoing breast conservation surgery were randomized to an axillary lymph nodal dissection versus not in patients with 1 to 2 positive sentinel lymph nodes. And the results of the study were quite encouraging because it showed extremely low axillary recurrence rates, and they claimed that axillary dissection was not mandatory in this particular patient group. Also, the rates of the arm edema that was associated was much less in those patients who were only being observed. But of course, as we know, and Dr. Rajan also presented in the previous talk, we know of the various pitfalls of this study, as a result of which it was received of tremendous critique. And then but then following the results of the ACOSOG Z11 trial, it did open the doors of our mind to whether there is that particular patient subgroup for whom we can consider de-escalation of axillary management. So then in the wake of that trial, we had the results of the IBCSG 23-1 study, wherein they randomized patients with T1, T2 disease with 1 to 2 nodal micrometastasis only to axillary lymph node dissection versus observation of the axilla. And their results corroborated with that of the Z11 study. The difference, of course, was that the Z11 trial included only patients undergoing a breast conservation surgery, whereas the IBCSG study included both breast conservation as well as mastectomy. And as you can see from the curves shown here, that there was no significant difference in the survival outcomes between the two arms. But if you look at the box that I have highlighted, the rates of lymphedema and other long-term surgical complications such as motor and sensory neuropathy was definitely a tad higher in the ALND arm. Well then, is there a difference in the survival outcomes and the side effects amongst patients undergoing axillary RT and versus an ALND? So 2 trials that looked at this was the AMAROS and the OTO-SO studies. I'm just comparing.
You have 2 minutes to conclude, please.
Yes, please. So I'm just comparing the two here. Now, both trials looked at ALND versus axillary RT in clinically node-negative patients with tumor size less than or equal to 3 centimeters who tested sentinel lymph node positive. And if you can see, there was no significant difference in the survival outcomes between the 2 studies. And also another point to be noted is the significant rates of lymphedema that was higher in those patients undergoing ALND studies. So the evidence is a bit hard to ignore. Coming to the question, can radiotherapy then replace axillary lymph node dissection after positive sentinel lymph node biopsy? I would like to agree, but with the caveat that the patients we consider this for belong to the same criteria as those enrolled on the AMAROS and the OTO-SO studies, that is clinically negative axillae, small tumors less than 3 centimeters, 1 to 2 positive sentinel lymph nodes, and tumors of good biology, strong hormone receptor positive, HER2 negative tumors, then yes. I want to highlight the results of this particular study by Dush et al., wherein they looked at the incidence of lymphedema on patients belonging to the NSABP04 study group. And if you take a look at this box in the lower left-hand corner, you will notice that the rates of lymphedema were quite significant even in patients undergoing a mastectomy alone. So having said that, while we are aware that any sort of surgical or maybe even radiation therapy, any sort of intervention to the breast for treatment can result in lymphedema, I think our aim should be focused on reducing the morbidity while not affecting survival. So having said this, my take-home message would be that yes, we can consider substituting axillary lymph node dissection by radiation of the axilla only, regional nodal irradiation in a carefully selected subgroup of patients similar to that of AMAROS and OTO-SO study groups. Whereas in those patients with T1, T2 disease, 1 to 2 axillary micrometastasis only, I think following the results of the IBCSG23-1 study, there is merit in considering no further axillary intervention, but in a carefully selected group of patients, those with disease with good biology, strong hormone receptor positive, HER2 negative tumors, etc. Now, what are the questions that I am still thinking about? In those patients with positive sentinel lymph nodes who are being considered for regional nodal irradiation, in the 2 studies, they underwent radiation. The radiation was delivered to all 3 levels of the axilla, as well as the medial supraclavicular fossa. So should all the patients considered for this undergo radiation to these areas, or can we restrict radiotherapy to only the 3 levels of the axilla? That is one. And the second question that I'm thinking about is which is that subgroup of patients for whom we should consider of radiating the internal mammary lymph nodes. So while I think it's great that we have moved away from just looking at the quantity of life that one has, and we are talking about the quality of life that we are giving our patients. Thank you very much for your patient listening.
Thank you so much, ma'am, for the detailed talk. Moving on, I request Dr. Bharat Chandra, Consultant Radiation Oncologist, Yashoda Hospital, Hyderabad, to join us for the next talk. Welcome, sir.
Yeah, very good evening, everyone. So first, I thank Dr. Nikhil for giving me this opportunity. I hope you can see my slides.
No, sir. No, sir.
Can you see my slides?
Not yet, sir. You need to share your screen, sir.
Just a second. I'm sorry. Yeah.
Yes, sir. Now we can see.
Yeah. So very good evening, everybody. I'll be discussing on a de-intensification strategy, which was presented at the San Antonio Breast Meet, where the idea here is trying to avoid radiotherapy altogether in a subset of early breast cancer patients. And this was the study presented at the San Antonio Breast Group. And here, as we see, adjuvant radiation is the standard of care for patients who undergo breast conservation therapy. But if you see, there are a clear subset of patients within the early breast cancer where we can think of avoiding this standard of care. And based on this idea, there are multiple randomized trials which have started but not yet published, which is IDEA, Precision, Lumina, Primetime, and Expert trials, which are looking for omitting radiation treatment by various parameters, few clinico-pathological parameters, and few taking into account the oncotype DX. When if being less than 18, they're thinking of avoiding radiation. So on these grounds, this single arm study was done. So just a brief history of whole breast radiation as a standard of care was developed since the EBCTCG meta-analysis published in 2011 clearly showed that giving adjuvant radiation to the entire breast post-breast conservation therapy had significant reduction in breast cancer recurrence rates with an absolute reduction of 15%, and which also translated in reducing the overall breast cancer mortality rate by 3.8% over 15 years. Then if we check out in the node negative patients, the absolute risk reduction in the breast recurrence was 15%, and also it translated to a reduction in cancer mortality by 3.3%. But the overall analysis, if we see a subgroup of patients with a higher age group, lesser tumor grade, ERPR positive patients who were taking tamoxifen, good surgical resection, the absolute risk further reduced for recurrences, which was only below 10% patients had a risk of recurrence, whereas absolute risk reduction in 15-year breast cancer mortality was only 0.1%. So idea of this trial comes from the thought of this subgroup of patients can completely avoid radiation if they are quite adherent to the hormone therapy. So the materials used were basically the inclusion criteria, which was assessed for stratifying patients from their electronic medical health records. And they have used Lumina trial criteria, where the Lumina trial is based on Canada, which is looking at the same ideology of de-intensifying treatment for early stage breast cancer treatments by omitting radiation treatment. So all patients' data were collected from the electronic health record from 2007 to 2016. And features like demographic features, tumor characteristics were recorded. And the analysis was restricted to only patients who were fitting in the Lumina trial criteria, who received radiation or who omitted radiation. And the primary endpoint was 5-year local regional recurrence rates across the groups. So what is the inclusion criteria? Patients should be aged more than 55 years of age, should have a solitary tumor unifocal, only ductal, tubular, or mucinous histology were included, no luminal. T1 and 0 patients, grade 1, grade 2, ERPR positive, HER2 negative, no LVI, margins of surgery should be more than 2 mm, and KI should be less than 13.25. And all agreed to start endocrine therapy. So 110 patients met the Lumina trial criteria. 82 of them received radiation, only 28 had omitted radiation, and there was endocrine treatment adherence information available only for 96 patients. Patients were characterized as endocrine treatment adherent and non-adherent based on if a patient received more than 5 years of endocrine treatment or who had discontinued the treatment only because of disease recurrence, he was termed as endocrine adherent patient, and anything else, they were termed as endocrine treatment non-adherent.
So sorry for interviewing. You have 1 minute left to conclude, please.
So if you see the treatment groups, the only most important thing to look out here is patients who omitted radiation are at a higher age group patients, and rest all parameters were matching in both the groups. And 5-year loco-regional control rates in all the patients, if you see, RT alone had 100% no recurrence rates, but endocrine treatment alone without RT had only 94%. 6% had tumor recurrences. But if you see endocrine treatment adherent patient group, there was no difference between radiation treatment or endocrine treatment alone. Non-adherent, yes, radiation was much better. The Kaplan-Meier shows also no difference. So the median endocrine treatment duration for endocrine treatment adherent patients was 60 months, whereas non-adherent was only 19 months. And if you see, as I told you, the 5-year local recurrence rates with RT omission versus radiation for non-adherent there was a 17% difference in local regional recurrence rates. So these are the other trials which are still ongoing, multiple phase 2 trials, and only one natural study from Denmark, which is a randomized controlled trial, which is trying to compare whether partial breast radiation versus complete omission of radiation is good in very early stage breast cancer patients. So the Lumina, this abstract which was presented just throws us a light towards trying to avoid radiation for a very minute subgroup of early stage breast cancer patients. But the most important thing was they had to have a good adherence to endocrine treatment. Thank you.
Thank you, sir. For our next talk, I request Dr. Shayan Paul, Senior Consultant Radiation Oncologist, Apollo Hospital, Kolkata, to join us. Welcome, sir.
Thank you. Am I audible?
Yes, sir, you're audible, sir.
Yeah. So thank you, Dr. Nikhil and the organizers for inviting me to talk in this forum. So the abstract I'll be presenting is polygenic risk scores predict toxicities in racially diverse breast cancer patient following radiotherapy. So the background is actually there are 3 types of side effects. One is fatigue, fibrosis, and breast asymmetry, which is often found around in 40% of long-term survivors post-radiotherapy. And there have been many studies like with the patient, tumor, and treatment-related characteristics, and they try to find the individuals who are at risk of developing these side effects. And there has been some single nucleotide polymorphism which has been found, like the one in TGFB1, and they are associated with long-term breast fibrosis following radiotherapy by genome-wide association studies. So, however, these findings are often not consistently replicated in various cohorts, particularly those with racially diverse patients, indicating that these significant SNPs, which has significance P less than 0.005, or clinical factors alone may not provide enough information to determine individual risk of radiation-related toxicities. So their hypothesis, next slide, please. So their hypothesis was that the polygenic risk scores derived from the GWAS summary statistics of a large number of potentially significant SNPs, which has p-value of less than 0.05, have the potential to improve risk prediction, especially by using GWAS data of a racially diverse cohort. So they have taken 176 patients, the median age of 55, and 54% are white, 44% are black, and 2% others. And radiation dose given is the standard radiation dose, around 50 gray plus boost or 39.9 gray plus SIB. And around 40% patients have received supraclavicular fossa radiation, and 66% received chemotherapy, and 71% have received endocrine therapy. Next slide, please. So how they have calculated the percentage breast retraction? assessment. So from a digital photograph, as you can see, the left side is the normal breast and the right side is the irradiated breast. So A2 minus A1 plus M2 minus M1. Root over A2 minus A1 plus M2 minus M1 is the best retraction assessment. And the reference is root over A square plus M square. That is the reference length. So the percentage will be BRA divided by reference length into 100. It's a very simple mathematical calculation. Next slide, please. And by ultrasound studies, so they have measured the skin thickness. Next slide, please. So, so they have measured the skin thickness with ultrasound prior to RT, during RT, 1 month post RT, and 1 year post RT, and they have categorized the toxicities. So according to the thickness, increase in thickness, they have categorized from grade 1, grade 2, and grade 3. Next slide, please. So the method. So method is that actually they conducted 3 prospective longitudinal studies of breast cancer patients treated with whole breast radiotherapy with or without regional nodal irradiation. 3 things: fatigue, skin thickening, and breast asymmetry were assessed before and 12 to 18 months post radiotherapy using the following clinical measures that I have already explained: percentage breast retraction assessment, skin thickening, and fatigue assessment by multidimensional fatigue symptom inventory, MFI. So and profiled genome-wide SNP data from peripheral blood sample of the enrolled patients. There are African ancestry was 44% and 56 for European ancestry by Affimerics arrays, and imputed genotype SNPs to 1000 genome phase 3 reference panel. So genotyped or imputed SNPs with imputation R square more than 0.3 with minor allele frequency greater than 5% were analyzed in the GWS data with baseline post radiotherapy and changes in the 3 parameters, or the correlation was they tried to found. So GWS was first conducted separately in African and European ancestry samples and then combined by meta-analysis for baseline and post radiotherapy measurement. Joint GWS was conducted on all samples for the change phenotype, as they observed no heterogeneous phenotype distribution for samples of different ancestries. And PRS are derived using the GWS summary statistics for each phenotype. Next slide, please. These are the significant SNPs and phenotypes. I'm not going into the details because I have limited time. So next slide, please. This is the phenotype and the polygenic T-score correlations, and where the p-value is less than 0.05. Next slide, please. This is the plotting of the phenotype and R square explained by polygenic risk scores. Next slide, please, for 3 parameters. So the results, this is an important one. So they have found 12 independent significant SNPs for baseline and post radiotherapy measurement of the 3 parameters, that is PBRA, STRA, and MFI, all of which were identified only in patients of African ancestry and not in European ancestry due to low MMF, that is less than 5%. So all post radiotherapy polygenic risk score are significantly correlated with corresponding baseline and change PRS. So importantly, PRS has accounted for 76%, 73%, and 79% of variance of changes in the 3 parameters after radiation. So when clinical and treatment-related factors like radiation dose, chemotherapy treatment are added to additional covariates to the respective PRS, the prediction R square increased to 92%, 96%, and 96% for changes, the 3 changes, PBRA, STRA, and MFI respectively. Next slide, please. Next slide, please. Yeah, so I'm not going into details in this slide. Rather, I'll just tell you the conclusion, because this is just the plotting of the 3 risk factors. The conclusion is their finding indicates that over 70% of variation in fatigue, skin thickening, and breast asymmetry changes experienced by breast cancer patients after radiotherapy may be explained by PRS derived from SNP data profiled from blood samples prior to radiotherapy. And genome-wide significant risk SNPs of baseline and post-radiotherapy measurement of the 3 parameters, PBRA, STRA, and MFI, are found only in samples of patients of African ancestry. So they have said future studies aimed at replicating their finding in large cohorts are needed. So the clinical implication, what I could find is maybe in the patient with African ancestry, they might be having a little more risk of developing the post-radiotherapy cosmetic outcomes and fatigue if these SNPs match in their gene sequence. So I don't know, maybe we need more studies, more larger studies and clinical studies to validate this finding. Thank you.
Thank you so much, sir. For our panel discussion, I request our presenters, Dr. Firoz Rajan, Dr. Bharat Chandra, and Dr. Shayan Paul, sir, to be around. Moving on to our panel discussion, I invite Dr. Sapna Nangia, ma'am, Senior Consultant Radiation Oncologist, Apollo Proton Cancer Center, Chennai, to moderate the discussion. I invite our panelists, Dr. Veda Padmapriya, Senior Consultant Breast Oncology and Oncoplasty, MGM Healthcare, Chennai. Dr. Vijay Bhaskar, Senior Consultant, Department of Radiation Oncology, Apollo Hospital, Bangalore, and Dr. Pradeep Kumar, Consultant Radiation Oncologist, Yashoda Hospital, Hyderabad, to join us. Welcome, sir. Welcome, ma'am.
Good evening, and thank you very much, Dr. Nikhil, for inviting all of us for this panel. The talks that we are going to discuss today, I'm just bringing my presentation onto, let me just share my screen. But what I want to say is that it's very clear that the theme that is there is basically of conservatism. So conservation. Sorry, I'm just trying to. Can you see my screen?
Yes, ma'am. We can see your screen. Just make it full screen.
Yeah, just a moment. Yeah. So as I said, the theme seems to be basically about a conservative approach for axillary treatment and substitution of axillary dissection with axillary radiation, omission of radiation in a select group of patients, and the importance of compliance with hormone therapy in deciding that, and genomic information for tailor-making treatment, which is of course some way to go, but it's sort of, this is one field where radiation oncologists have actually been a bit lagging behind. So perhaps this is just adding to our knowledge as far as this is concerned. So the first study that has been studied is the Synodar, which was presented, was the Synodar 1 study. And the Synodar 1 study, the basic, what it tells us is that omission of axillary dissection in patients with small volume sentinel lymph node positivity does not impact survival or recurrence risk. So in this background, I would like to ask Dr. Firoz, the surgical oncologist, and Dr. Veda, as to how they choose the patient in whom they are going to omit further axillary dissection in a patient who has low volume sentinel positive. Since this is a decision they are often taking on the, in the OT.
Ma'am, Dr. Veda haven't joined yet.
Is Dr. Firoz here with us?
Yes, sir. Yes, ma'am. He is there, but
can I request Dr. Firoz to give us his opinion on this? So I think perhaps Dr. Firoz is not able to join us. In which case I would like our radiation oncology panelists with Dr. Pradeep tell us what is his comfort level with a surgeon having omitted axillary dissection.
Yeah, good evening, ma'am. Thanks for inviting me here. So as we have been seeing that major discussion is about conservative treatments. So we have this new concept of sentinel lymph node biopsy coming up. So if the patient is undergoing sentinel lymph node biopsy, that helps us in deciding whether the surgeon can go for axillary lymph node dissection, or they can be going for conservative with radiation itself. So if nodes are positive, they can straight away go for axillary lymph node dissection. And in case if there is negative, and I don't think they will agree for no need of dissection, they can go for conservative treatment. In case there is any micrometastasis, again, our new guidelines always are suggesting not to go for axillary lymph node dissection. And in case if they are setting up, as we have seen in the of the trial, if it is a low burden disease, as well as RT is already planned, and I think you can omit lymph node dissection, straight away go for radiation.
So one of the things that you feel is that this is a situation where radiotherapy is already planned. That is where a surgeon might omit doing further dissection.
Yeah.
And if Dr. Firoz has joined us, maybe he can guide us about what other factors play on his mind when he's taking that decision. So may I request my other panelists, Dr. Bharat, to talk about this? What does he think would be other parameters that a surgeon should be looking at?
Bharat, are you around? Dr. Bharat? I think we also have Dr. Vijay Bhaskar also, who is...
Yeah, Dr. Vijay Bhaskar, would you like to discuss, what you think the surgeon would be paying attention to?
I think Dr. Pradeep rightly said, if sentinel lymph node biopsy is showing there's a low volume disease, I think the axillary lymph node dissection can be avoided, and we can go ahead with as planned radiation treatment.
Yeah. So of course, I mean, what I basically would like to stress here is the fact that these trials have very strict eligibility criteria.
Yes, ma'am.
And that this should not. This is only strictly for T1, T2 patients. And if we see Synodar 1 as well as the previous trial, there's almost like an overload of luminal patients, so luminal A, luminal B, and Synodar 1 has the authors have already expressed that they have excluded patients who are 40 years and lower, and because of the preponderance of HER2/neu positive and ER negative disease. So in a sense, when we are taking that decision, it should be very clear, as Dr. Manjula also mentioned, that the eligibility criteria of these trials should very much be there in the back of our mind when the surgeon is taking this decision. So the eligibility criteria are this 40 to 75. And yet there is something to be said about this, and I will discuss that slightly later. So this is what they have said, that they have definitely excluded patients who are less than 40 years, because they think these are the things which are common in younger patients: ER negativity, triple negative, high grade, LVSI. And so perhaps this should be cautionary for the surgeon also. However, I'd like to mention here that there are two ongoing trials, the POSNOC and the INSEMA trial, which have the same arms, but which are actually recruiting younger patients too. So the POSNOC is recruiting patients who are 18 years and more, and also recruiting patients who have multifocal disease. And the INSEMA trial is actually recruiting patients who are more than 35 years of age. So yes, as things stand, we still have to be careful, but ACOSOG and the other trials did recruit younger patients also. So coming to the radiation oncologist's choice. Now, ACOSOG and Synodar really were very conservative in their radiation approaches also. And what I would like to ask Dr. Vijay Bhaskar and Dr. Pradeep are that what is your choice? If the patient has undergone only axillary sentinel lymph node and it's positive, macrometastases, what is the choice of field that you would go for?
Ma'am, if there is a macrometastasis, we have to go for high tangentials.
Would you include the entire axilla? Would you treat the entire axilla like the Amaros study? Or would you go for high tangents like
high tangentials,
Amaros or
ma'am. We go with high tangentials.
You would go for high tangentials.
High tangentials.
And Pradeep?
Yeah, I agree with Dr. Vijay Bhaskar. It's the same.
Okay, so are there any other, Sayan, what would you do? Are you there?
Ma'am, probably I'm more inclined to treat the entire axilla in these scenarios.
Yeah, so I would also be more inclined to treat the entire axilla. Yeah, please go ahead.
So, because I don't think it's very difficult treating the entire axilla, because even with the older techniques also people have treated, like when we didn't have this, I mean, the image guided techniques or this newer techniques, like only with, even with mobile beam also people have treated. And like I can remember the ACPGI data, Professor Inadatta's patients. I was fortunate to see some of the patients follow up, and they tolerated very well. The side effects were not very much, and he also, you know, that he used to preserve the simulation films also in the file, so we could see the plan also. This simple plan, 2D plan, treated the axilla also. I mean, and with the newer techniques, why do we leave the axilla? I mean, any level of axilla. So I will be more inclined to treat the axilla.
So interestingly, in the Amaros trial too, about 20% of patients did have high tangents, not low tangents, and some had posterior axillary boosts also. So I do believe that these are two contradictory lines in which we are discussing about how to deal with an undissected post-sentinel lymph node positive. So I do believe that this is, in radiation fields, this is controversial, in that, as Dr. Pradeep and Dr. Vijay Bhaskar mentioned, they would be more comfortable with tangents. As Sayan mentioned, I also would be more comfortable with a full axillar treatment. And in fact, in the Amaros trial, even the medial lymph nodes, supraclavicular lymph nodes were treated. So this is, I believe, a controversy that is unresolved, and that is something that will have to come from the radiation team. So as I said, in Amaros, full axillary treatment was done, and yet the lymphedema rates were actually less than half, wherein, so as I said, these are two different approaches. The ACOSOG and the Amaros trial is looking at axillary radiation. So is the AUTOSOR trial. However, ACOSOG and IBCSG actually did not go in for axillary radiation. So I want to ask, Dr. Vijay and Dr. Pradeep and Sayan, Dr. Sayan, what is their strategy for management of micrometastases? What is, if the patient has sentinel micrometastases, how would you treat the axilla? Dr. Pradeep, how would you like to treat the axilla if a patient has micrometastases, or would you like to let it be?
Okay, if the surgeon has seen the micrometastasis in lymph node biopsy, I think most probably they will not be going for axillary lymph node dissection. And as already it is considered as a conservative therapy, lumpectomy and BCG, definitely we are going for radiation. So I don't think there is need for adding axillary lymph node irradiation. Just we'll go with the whole breast irradiation.
True. I agree with you. And Dr. Vijay, what do you think?
Ma'am, again, depends on the tumor characteristics. Again, as you mentioned, grade and the margins also play a major role here. So based on that, we again decide on our radiation fields.
Very right. So if you feel that if there is an ER negative tumor or there is a TNBC, you would be more tempted to be generous. Is that so?
And now the concept, as Pradeep rightly said, is when you're having a micrometastasis with sentinel lymph node, we play very conservatively.
And Dr. Sayan, what do you have to say about this?
Yeah, my opinion is also same. Like I will usually not treat axilla if all other parameters are favorable. But yes, if it is a TNBC case, then I might think otherwise. I mean, according to the risk factors.
Very right, very right. So we do know from literature, of course, so there are basically, axillary micrometastases and ITCs. We know from retrospective data that they are not an indication for post-mastectomy radiation because the margin of failure is very low. And in the IBCSG study, which was discussed by Dr. Manjula also from Dr. Reshma Jaksi's lecture, so there were almost about 20% of patients, in fact, after micrometastasis, received only Elliott treatment. So they received only intraoperative treatment. 3% received no treatment, and yet there were no axillary failures. And so unless, as Dr. Vijay mentioned, unless there are other indications for radiation, sentinel, just micrometastases in the sentinel lymph nodes, for the youngsters in the audience. So that is not going to be an indication for radiation. I do remember, when we first confronted our first patient with micrometastases, we went through a literature search to find out what we should do. And finally, we treated the patient with high tangents. But now I believe that the information is much more clearer with both these studies being available. So now we come to the other topic. I am not going to discuss the SNPs and fibrosis. That is for the future, for pointing for us. So basically the question of omission of radiation after breast conserving surgery. So I just want to ask really genuinely out of curiosity, how much do you think is, and Dr. Nikhil, maybe you could tell us, maybe the patients follow up more with the medical oncologist. What is the situation of adherence to AIs? Is it really so much of an issue?
Yeah, I think we have some issues with the AI treatment, no doubt about it. But in general, if you ask me about the compliance part of it, I think majority of the patients, I would say almost 90% of patients do complete their recommended therapy as far as the AI is concerned. So we do discuss a lot about the toxicity part of long-term AIs with the patient. But in the real life situation, I think with the due counseling and with the due compliance and explaining the compliance to the patient, I think it is possible to treat with majority of patients to complete the AI basically.
So because it appears to really hinge on that, isn't it? It's really
Absolutely.
hinging on the fact that that is, an unknown actually. So in the real world, the compliance to AIs is an unknown factor, and that is what. But what I want to also again, question the radiation oncologists here. After the data that we have, and which is going to be the debate coming in the future, the next topic, the 5-fraction treatment, and the fact that now we can do APBI in 5 sittings after the Italian data is here. So do you really think that omission of radiation is so important?
Omission of radiation is nowhere recommended right now, even for the early breast. The characteristics what you're showing on your screen is an ideal for an APBI. But as of now, there is no.
Sorry, I think we are losing you.
Okay, ma'am.
Can I comment on this, ma'am?
Yes, please.
Yeah, so I'm in favor of de-escalation in breast cancer management, because breast cancer management takes a long time and it is like very uncomfortable for the patient, both physically and emotionally. So I think if all the criteria matches, all are good criteria for elderly patients, and if they are, we are sure that their compliance is good and they will be taking AI for 5 years. we might omit radiation in elderly population, not over 55 years, maybe probably more than that, probably more than 65 years or so. And the thing is that, yes, you are right, because we have now fast forward trial and people are being treated with 5 fractions. Even the whole breast can be treated with 5 fractions, particularly in this category, this ER positive, HER2 negative, and smaller tumors. So that is an option, giving a fast forward radiation. If we are not very sure that patient will be taking AI for 5 years and will not be lost to follow up.
However, we must again stress, the choice of the patient. So it's very clear from the Lumina study also, though their age range seems to be 55 only. However, they were very clear that no grade 3 or lymphovascular invasion or extensive introductory component. So definitely the choice is going to be very, very rigid about. So do you think it really adds to anything after we have, so of course we know that on omission there is an issue, but looking at the fact that we had already some data from CalGB and from the PRIME study that was presented last year, which also said something similar. So do you think that this study is practice changing? Which is what...
I'm sorry for intervening. You have 2 minutes to conclude.
We have to stop now?
Ma'am, we have 2 minutes. 2 minutes.
Okay, please go ahead. Yeah. So do you think this is practice changing as yet, or are we waiting?
Ma'am, PRIME 2 study I feel it is practice changing.
Okay.
I mean, we might find a cohort of patients where we can actually omit RT.
Yeah.
But the selection must be very crucial, selecting the patient.
But would you confer somebody a 10% risk of local failure? Is that okay?
That is a bit high, and I know that's a bit high. So, but we can discuss with the patient and take her opinion also regarding this.
Right. And Dr. Pradeep, what is your opinion on this?
Yeah, again, this question is a debatable thing. And for me, if the patient is very elder, like beyond 70, I try to give it as an option, but I don't try to make it as a standard that this should happen, because we are coming to a stage when there is a lot of hypofractionation coming up, and it's very easy to treat the patient in a week and send them back. So it definitely, we don't leave any threads untied. So I definitely give a choice to the patient if they are so reluctant to take radiation, then definitely I'll go for it.
And Dr. Vijay Bhaskar, what is your view on this?
As I mentioned earlier, I would definitely go with APBI, hypofractionated schedules, especially when I get a patient with the characteristics what you showed me on the screen.
So do you think that compliance to AIs would play on your mind as the Lumina trial?
Ma'am, whatever data we saw is all Western data, whatever the data regarding endocrine adherence. But in our population, endocrine and non-adherent population is much higher. So I would definitely finish off radiation and better avoid local recurrence.
So you would be concerned about,
Yes,
endocrine adherence. You would be concerned about
definitely
adherence. Right. So I will sum up then, because I think we have run out of our time, that we will omit axillary lymph node dissection only in selected patients. Of course, we didn't have a surgeon's opinion, but I believe that that is correct, that in carefully selected patients, we may omit axillary lymph node dissection if it is very clear that the patient is going to receive radiation anyway, which would perhaps be the elderly axillary lymph node, elderly or older patient with ER positive tumor and undergoing a breast conserving surgery. And axillary radiation, I believe that we have not answered that question of how we would do the axillary radiation. And I believe that is the results of the panel actually reflect really the absence of evidence one way or the other to say which is superior, high tangents versus treating all 4 groups. In fact, there is a question mark. If the patient has a medially placed tumor, perhaps we should also treat the internal mammary lymph nodes. And then omission of radiation in early breast cancer, there again, I believe that it becomes like an individual philosophy of the treating doctor, wherein, yes, but it does impact our trial. So I do believe our practice. So I do believe that each of these studies, it is an ongoing process wherein we are becoming more and more conservative about treating the axilla and about treating early breast cancer in the elderly. And this is like evolution. So it is an evolving field, and these studies also contribute to that. So thank you very much to the organizers. On behalf of the panelists, I'd like to thank Dr. Nikhil, and myself, I would like to thank Dr. Nikhil for this opportunity.
Thank you very much, ma'am.
Thank you very much.
Ma'am, I thank all our faculty members and panelists for a wonderful and detailed discussion. Moving on, we have an interesting debate coming up. 1 week of whole breast RT is the new standard of care. Speaking in favor of the topic we have Dr. Nandita Shashikaran, consultant clinical oncologist, AAG Hospital, Hyderabad. Hello.
Hi, can you hear me?
Yes, ma'am. Welcome, ma'am.
Thank you.
Hello. Opposing the same will be Dr. Shankar Vangipuram, Senior Consultant Radiation Oncology, Apollo Cancer Center, Chennai. Welcome, sir. Hello.
Yeah, thanks so very much. Please go ahead, Nandita. I'm listening.
Okay.
Just a second, ma'am. Before moving on, sorry to interrupt. Each side will be having 8 minutes for your presentation and 2 minutes for the rebuttal session, ma'am.
Okay.
Thank you.
Okay. All right, I'll be quick. At the outset, I'd like to thank the organizers for inviting me to talk about this lecture topic and to be on the side of this debate, that 1 week of whole breast RT is the new standard of care. Before we start, I'd just like to make one thing very clear, that there is no indication to use more than 15 fractions of radiotherapy in breast, chest wall, or nodal RT. And this is based on several trials involving greater than 6,000 patients. Anybody who's using 25 fractions still, I don't think there's any point going forward with this debate. So talking about this new 1 week schedule versus the standard 3 weeks of whole breast RT, how do we prove that this is as good as the 3 weeks? You'd need to demonstrate efficacy, safety, and to see whether there are any subgroups or exceptions. So we'll go through all of this. So all of this is, so this debate is entirely based on this wonderfully designed trial called as a Fast Forward, which was published in the Lancet in 2020. This was a well-designed phase 3 randomized non-inferiority study, and they recruited over 4,000 patients who required whole breast radiotherapy or chest wall alone radiotherapy. The standard arm was a 40 gray in 15 fractions, and there were 2 experimental arms, 26 and 27 gray, given in 5 fractions over a period of 1 week. Now, these doses are not arbitrary. They are basically derived from the previous trials and have there was found to be equivalent to the 40 gray in 15 in terms of normal tissue toxicities and tumor control. So efficacy was basically, they had a predefined non-inferiority criteria of 1.6% ipsilateral breast tumor relapse, a very strict, stringent criteria. And pleasantly, when you look at the Kaplan-Meier graphs, you can see that the relapse rates are the least in the 26 gray arm as opposed to the standard arm. However, this was not designed to test superiority, but without any doubt, it demonstrated non-inferiority. Coming to other secondary outcomes like distant relapse, mortality, loco-regional relapse, there wasn't any difference between the standard arm versus the 1 week schedules. So I think out of the 3 boxes, we've definitely ticked the efficacy box. So next we'll talk about safety. When you're talking about safety, you look at both acute and long-term toxicity. Acute toxicities were very minimal. Grade 3, grade 4 were almost non-existent, and the usual grade 1, grade 2 toxicities. So extremely mild acute toxicities. And then coming to late toxicity, there was a very rigorous assessment of late toxicities. They were clinician assessed, patient assessed, photographic assessment, and these were done at multiple time points. And as a result of several assessments, you have to apply a Bonferroni correction for multiple testing. And so a p-value of only 0.005 was considered to be statistically significant to prove that one group was inferior to the other. Looking at all the multiple toxicity criteria, distortion, shrinkage, induration, telangiectasia, edema, discomfort. Just to summarize this busy slide, there was absolutely no difference between the 40 gray and 26 gray arm in any of the assessments. However, the 27 gray arm did have more shrinkage, edema, and induration. In terms of serious adverse effects on heart and lung, these were almost non-existent. So I think the second box of safety as well, we've ticked for the 26 gray in 5 fractions, that it's as good as a 3-week regimen. So once these results were out, the Europeans and Americans, as usual, started criticizing the fast forward data, and they came up with these sort of arguments that ipsilateral breast tumor relapse continues beyond 5 years and that longer follow-up is required, and may not be relevant in higher risk subgroups. Late effects as well increase with time. So looking at ipsilateral breast tumor relapse beyond 5 years, I absolutely agree that relapses do increase over a period of time. However, the hazard ratios remain absolutely stable at 5 years as well as 10 years. So if a certain regimen is considered to be superior at 5 years, it will continue to be superior at 10 years. And so 5-year data is an accurate reflection of 10-year relapse rates. And so there is no doubt that the 5-year data of fast forward is going to remain the same at 10 years. So this argument, I think, is not valid. The next argument that it may not be relevant in higher risk subgroups, they were very nicely stratified prior to recruitment as less than 50 years in grade 3, so close to 40% were high risk. And in this forest plot, you can see that none of these groups really had any favorable effect with the 40 gray against the 26 gray. The previous trials as well showed similar results, that hypofractionation did not adversely affect people in the higher risk groups. So this argument as well is not valid. Now the third argument, that late toxicities as well are likely to increase with time, again very similar to the previous argument. It does increase with time, but the hazard ratios remain stable, and so they're not going to change. The difference between the two groups is not going to change between 5 years versus 10 years. And these absolute numbers of late toxicity with shrinkage, induration are so small that I don't think this will really matter to a patient. So the third argument is also null and void. Toxicity may be more in women with large breasts. I've heard this a lot as an argument for people giving the 25 fraction regimen, but this is absolutely wrong. There is no contraindication to give patients hyperfractionation even in the large breast, and so also even the 26 gray arm proved the same thing. Radiobiologically as well, the 26 gray regimen is much gentler than the 50 gray regimen in terms of late toxicities, if you consider an alpha by beta of 1.8 to 2. So there's absolutely no reason to believe that long-term effects will be worse. So the fourth argument as well is null and void. So I think we've ticked all the boxes: efficacy, safety. There aren't any subgroups or exceptions. And if my colleague is going to quote this paper in his argument, this was a paper published in a German trial, in a German journal by the DGRO group. Now, this is the only paper that's criticized the fast forward and actually published, but I'd like to tell you that this is statistically flawed. They have misinterpreted the p-values and not really applied the correction of multiple testing. And they've used the same conclusions as fast forward and come to a totally different conclusion. So I would urge you to disregard this trial and not quote this as an argument against the fast forward. So with that, I rest my case. I am absolutely convinced that the 1 week 26 gray regimen is the new standard of care. However, I would not use it in nodal irradiation as yet until the nodal sub-study results come. And with that, I will hand over to my colleague. Thank you. Dr. Shankar?
Yeah, very much here. Thanks, Sangeeta. Thank you so very much. Wonderful presentation. Really like that. Okay, so there we go. Good. Able to see my screen?
Yes.
Okay, good. Thanks, Nandita. Wonderful presentation. Really appreciate the way you have done it. I'm really very happy for the simple reason that you have changed your goalpost, and I believe you started practicing and jumped from moderate fractionation to ultra hyperfractionation. So let me set the stage by drawing your attention to the knowledge information matrix, which we typically apply to classify the risks which are based on the knowledge that we have about them. If we see, they are broadly categorized into known, and which is again subdivided into known knowns and unknown knowns, unknown and which are known and unknown to us. When I say known knowns, that is what typically exactly what Nandita has alluded to. So what we're really not focused on to were the unknowns, known unknowns and unknown unknowns, which I'll be more stressing about. And as rightly alluded to, 5 weeks radiation schedule is no longer defensible, and 3 weeks remains to be the standard of care, regardless of the subgroup, whatever subgroup we are speaking about. Moderate hyperfractionation is the standard of care, and colleagues from RCR have actually changed the practices based on one particular clinical trial which has been published in just 9 months ago. So whenever we are speaking about moving a needle, we need to understand go a little depth into the kind of study which has been published, the equivalent cancer outcomes, and rule out any surprises if they are there. This schema was already alluded by Nandita. The primary endpoint, of course, is IBTR, and secondary also were very clearly, very well defined, wonderfully conducted clinical trial. No qualms. It's about a non-inferiority clinical trial, and these are the known knowns which I really do accept, the endpoint or with regards to the late effects, which Nandita already alluded to. So my attention is more to the known unknowns. Now, the inclusion criteria I put forward in the paper are PT1 to T2, N0 to N1. Let me just pull out the actual inclusion criteria. 50% or more than 60 years, 94% had breast conserving surgery, 70% grade 2, 70% T1C. The median tumor size was 1.6. There is 90% negative LVI, 80% node negative, less than 3.5% neoadjuvant, and 25% received boost. Now, this is a picture which actually where 93% have seen BCS, and the results were typically PT1 N0. So you have essentially options right there, APBI and observation. And this has been incorporated in the guidelines of HCN. And if you look into the Florence trial, which can essentially correlated APBI versus the standard fractionation, the clinical inclusion criteria has been exactly same as what you have seen in Florence. And if we look up into the prime trial, observation also is something which is very similar. We really don't need to rush to treat for such kind of patients. The in-breast tumor recurrence with no RT with just 4% at 5 years, and that's pretty acceptable is what I feel. And mastectomy, how safely can we do it? Use ultra hyperfractionation. If you look into the details as to what was included, only 6% of patients have received mastectomy. And lymph node positivity, I'm very thankful that Nandita said she's a little skeptical. But again, if you look into the positivity, only 18% were positive. Almost 82% were negative, and that's the kind of picture where you are really worried about when you're using hyperfractionated, ultra hyperfractionated doses for a very large field. You're really worried about the toxicities. And oncoplasty, it's just 3% of the patients, they have done oncoplasty. So all these details which you see, essentially let us figure out the other problems which were there in the planning. The protocol which used just tangential opposed pair of beam arrangements, and of course this particular constraints which have been alluded to in the trial. what really I look for is a validation study. Whenever I try to look into do something new, innovative, you need to have some validation in place. Added to it, there are triple troubles which happen because of the kind of hotspots which would get penalized when we are using severe hypofractionated doses. And coming to the boost was given in 24% of patients. There is no clarity on the boost dose which needs to be given. Out of this 24% of patients, 77% have received 10 gray and 16%, 20% have received around 16 gray, when all of us really know that the 16 gray boost dose really produces more fibrosis. So now let us put this particular data, which from the fast forward into the Indian context. The nearest correlate is the TMH hypofraction data, which is done in a sample size of 1721. T2, T3 were 50 to 25, 75%, 83% were grade 3, 48% had mastectomy, 60% had lymph node, and 50% had boost. So essentially, we are trying to compare apples and oranges, and all I look for is just simple evidence. And if you put this particular evidence into the Indian context, it really doesn't ring the bell. Now, the most important thing is the unknown, the surprises which I see. Most of this is because of the 6 years data which you see right there. The BMI, all of us really know that patients with high BMI, where breast volume getting irradiated is more than 800 cc, the incidence of the skin toxicity is high, and this has not been reported. The same with the breast lymphedema. Whenever you're treating a large breast size, you can see while 14% only had axillary clearance and 19% had positive lymph nodes, and we are not really sure whether the lymph nodes have been included in those patients or not. And most important thing is the hard doses. I would like to remind my colleague about the linear dose volume relationship with the heart, which had come from Darby. And this increase started at 5 years and peaked, and it just continued up to the third decade. Here, we are speaking about established dose volume effect with regards to cardiac effects. We really need to figure out if there is any dose fraction effect. And as I said, with 6 years follow-up, it's too premature to say, when all we know is radiation has multiple effects with regards to the myocardium, pericardium, and all the structures which you see right there. And the third important thing, and the last important thing, is around 74% of these patients also received chemotherapy and trastuzumab. Now, please understand, whenever this particular modality is given with radiation therapy, again, as I said, this particular trial has seen 26% drop in the left ventricular ejection fraction, and that's more common in patients more than 55 years, where there was a real statistical significance. The trial, fast forward trial, the median age was around 60 years. So all said and done, with 6 years follow-up, it's too premature for me to jump the guns and say, okay, this is the way forward, and I would rush to change my practice. Now, there is always a conflict of interest which actually holds us back. Now, I would take the Pradhan Mantri, whatever scheme, the CGHS scheme, which actually covers the rates, cover 90% of cancer care in India. The amount which these people give when hypofractionated protocol is just $42,000, 42,000 rupees is $560. And if 20% is knocked away as a professional fees, radiation Parsi has high fixed cost, which includes, you cannot cut the salary you pay for all the personnels who are working, the support services, and we ask for new equipment. So essentially, there will be downstream effect. And added to the worst, today, as you can see, CGHS dues have exceeded to 100,000 crores, and private hospitals have stopped. Now, this financial impact of hypofractionation is something which we really need to look into, and we really cannot use a generalized adoption protocol. And this is not just a problem in our country. which is just horrible, but also in developed countries where there is 30 to 40% difference in the amount which the hospitals get. And if you look at
So sorry for intervening.
Last 1 minute. Last 1 minute. So if you look into the international guidelines, it's very clearly COVID guidelines. RT is something which is advised for tumors, very specifically node-negative tumors, and they do not require boost. So if I summarize, the fast forward is just single randomized trial, no long-term follow-up, no subgroup analysis, and it's just adapted in few centers. So it is still the hypofractionated radiotherapy, to me, remains the standard of care, specifically more in the Indian context. Extreme hypofractionation is a promising area, can be used in select patients. We need to exercise caution in using this, and more so it's advisable in a resource-constrained environment. So to summarize, there are very little known knowns. The known unknowns a lot, and unknown known, I'm really not really sure about it. So my humble request to Nandita is revert back to the moderate hypofractionation. If you started ultra hypofractionation protocol, as the evidence is still weak and does not suit the Indian healthcare system, and please allow us to protect our jobs as well, because that has a lot of downstream effects right there. And still, if you're doing it, please do not practice the protocol which they are advising, the tangential beams. Please use something like breath hold gating. Thank you so very much for your patient listening.
Thank you, sir. Thank you, ma'am. Now we'll be having the rebuttal, and each side will be having 2 minutes for this. Thank you so much.
Okay, so I just have a few things to add to Dr. Shankar's argument. So regarding the technique, even in the UK as part of the trial, patients who had left-sided breast cancer were mostly treated with DIBH, and only those whose those constraints were met would go ahead with the treatment versus not. About the argument about late toxicity and particularly cardiac toxicity, absolutely agree that longer the follow-up, greater the toxicity is likely to result. However, like I said, the hazard ratios remain the same at 5 years and 10 years. So if it increases in the 26 gray arm, it is going to increase proportionately in the 40 gray arm. And if you look at my if you looked at my slide where I was showing the radiobiological equivalence, heart being a late reacting normal tissue, you'd expect the alpha by beta to be 1.8 or 2 at the lowest. And in terms of that kind of alpha by beta, this is definitely gentler than the 25 fraction regimen and is equivalent to the 40 gray regimen. So I think it's maybe a bit uncalled for. The kind of the concern about cardiac toxicity may be a bit uncalled for. And patients with large BMI, you did mention that they are likely to have greater skin toxicity. Again, the same kind of argument about the alpha by beta ratios, that equivalent doses with low alpha by beta shows that toxicity even for normal breast tissue is likely to be less in this arm. And clearly the acute toxicity data as well from the fast forward trial showed that there was almost nil grade 3, grade 4 toxicity. So there's no cause for concern that it's likely to have greater skin toxicity, because that would have been apparent within the first few weeks of follow-up. And the discussion basically was about whether this is now standard for whole breast radiotherapy, and the patients who fit into this schedule of whole breast radiotherapy alone are by default those with lower risk breast cancers, and so the trial accurately reflects what is the normal distribution of breast cancer patients who fit into this category. And like I said, we cannot use it for higher risk patients who require nodal irradiation. That only time will tell whether the fast forward sub-study is positive. And you pointed out a very small number of node positive patients included in the fast forward. That's because the sub-study included, it's a separate group basically. So those numbers will be much higher in that sub-study. And from personal experience, I have worked in UK for quite a few years and have been part of the fast forward follow-up, and have seen patients who have even completed close to 9 or 10 years of follow-up and haven't really seen any cause of concern. In the Indian context, fortunately or unfortunately, our hospital doesn't treat patients under the schemes, the PMPJ or the CGHS. So I have to basically just decide based on what is clinical need of patients, and I think I'm very fortunate about that. But yes, for whole breast radiotherapy alone, I am convinced that this schedule is ready for clinic.
Yeah. Can I just ask only 2 questions, Nandita?
Yeah.
Number 1, how many cases have you done in India?
In India, about 3 over the last.
The fast forward trial has been published.
I've been in India only for the last 6 months, and over the last 6 months, only 3 patients required only whole breast radiotherapy. All the other patients I've treated required nodal RT, and those patients I have treated with fast forward.
Exactly. So my submission is, you are speaking in a conference which is focused to our subset. So majority of them really don't suit the kind of inclusion criteria in the fast forward. So I have been practicing since last 22 years, and it has been very, very rare that I encounter patients who are in T1 and all the criteria which we are speaking about. So honestly, if we try to extrapolate the UK trial to our context, the nearest representative, what I was saying is from DMH, and of course you are also aware of it, is something which we can kind of compare regarding the patient characteristics. Majority of them don't fit into those particular clinical contexts. Yes, if they fit and if they are good to accept it, whatever points we put forward, yes, you are free to do it. But having said that, when we are doing something in our country, let's fit ourselves into these shoes and speak for the patient. Thank you so very much. Sapna,
thank you, sir. Thank you, ma'am. I request Dr. Sapna, ma'am, to join us for her expert comments.
Well, thank you very much for inviting me for this. And that was a very nice and very spirited debate. And I have to first kind of confess that I have not started using fast forward. But I do believe that, it is basically, this is a phase of healthy skepticism. Whenever there is a new treatment that comes in, I think each of us will try and be careful about applying it. And more so in a population where where even with metastatic disease in certain subsets, we are talking about median survivals of 5 years. So naturally, there's a bit of, you could say that it is natural for us to tread carefully. So I do believe that we will eventually use 5 fractions. I do believe whenever there is a treatment which is helpful for the patient, I believe that takes precedence over any other considerations that one might have. And even with the boost, finally, even with a 5 fraction boost, you do cut down 1 week of the patient, the patient's trips to the hospital. So, and we do know that shorter treatments, I mean, I'm extrapolating, it's an unknown, as Shankar said. We don't know about, we do know that in moderate hypofractionation, we noted later that the fatigue was less. We have studies that tell us that the fatigue is less. So yes, I do believe that at some point of time, once we have overcome our concerns about the data, because what are the concerns about the data? Really, as Shankar said, it comes from a single practice. Finally, it comes from a single practice. It may be 4,000 patients, but it comes from a single practice. And then there is this issue of 27 versus 26. So if 27 was, not considered appropriate, that means 1 gray made that much difference, which is really a very small,
Exactly, ma'am. That were my concerns as well.
Yeah. And of course, QA becomes critical. I do believe that radiation departments are very stringent about QA. it's just about sort of treading carefully. After all, we, in the SABCS this year, where there was a similar debate, the lady who was speaking against the motion did mention about how central tumors in lung versus peripheral tumors in lung, there was an issue when the hypofractionation was too much. The concerns about the late toxicity are there. And of course, in our context, the data about nodal irradiation. But for somebody like me, I'm so used to sibbing my boosts that I find it, a little bit of an issue as to how you integrate the boost into fast forward. So yes, eventually it will be fast forward. That's very clear. But I guess personally, I feel that I would like to wait, but I am actually very comfortable with the idea that some of my colleagues, in practice would be comfortable using it. I believe it's evolving, and it's a question of some of us needing to satisfy ourselves some more.
Ma'am, I have one question for you also, if you don't mind, if you allow me to ask.
Please go ahead.
Yeah, ma'am. Ma'am, given the kind of case selection which fast forward trial had, how many of that will be what percentage of your practice will be that kind of patients?
So it's, again, I said this is really about philosophy. So for example, for the medial group, irrespective of what their size may be, etc., because of the previous 2 internal mammary lymph node trials, I would treat the internal mammary lymph node. So the medial group is out. That leaves only the very good volume, good type, small patients who would not, outer quadrant, small tumors. I agree. But eventually you agree, Shankar, that we will be doing 5 fractions.
Yes, ma'am, I do agree.
So Nandita's kind of little ahead of us on the curve. Eventually we will be doing it. We're just sort of waiting and seeing how it evolves.
Yeah, thanks so very much, Nikhil, once again for having
thank you so much. Thank you, everyone. And I think we are definitely running short of time. Thank you, Dr. Sapna, for filling in at the last minute. Thank you for your valuable insights. I think we'll move on to the next session. Dr. Firdaus, you can take it over. Thank you.
Thank you, sir. Moving on to our next section, I invite Dr. Venugopal Arroju, Senior Consultant Medical Oncologist, Apollo Hospital, Hyderabad, for the next talk. Welcome, sir.
Yeah, a very good evening to all. So I'm going to speak on keynote 522. So it's basically neoadjuvant pembro plus chemo versus placebo plus chemo, followed by adjuvant pembro versus placebo for early stage high risk TNBC. So if I exceed my time limits, please let me know. So basically it was presented at 2021 ESMO by Peter Smith and et al. So by study design, if you look at here, so basically high risk early stage TNBC they have taken, that is newly diagnosed T1C node positive or T2, T3, T4, N0, N1, N2, that is node positive or node negative TNBC. So were randomized to receive basically paclitaxel plus pembro 4 cycles, followed by ACR-EC 4 cycles plus pembro, followed by surgery, followed by pembro maintenance for a total duration of 1 year, versus paclitaxel ACEC along with placebo, followed by surgery, followed by placebo. So basically, the study endpoints were PCR and event-free survivals in the intent to treat population. The secondary endpoints, we have PCR OS and PCR EFS OS in the PDL1 positive population, and we have the exploratory analysis which we look. So the prior analysis which were done at interim analysis 1, if you look at primary path CRs, so with pembro plus chemo, we had path CRs around 64.8%, whereas with chemo alone, path CRs are 51%. That is delta PCRs being 13.6%, and which is statistically significant. So this was the first EFS analysis. Later, this is interim analysis 4. We have got the final EFS data. So this is EFS rates at 36 months. That is 3 years EFS. If you see pembro plus chemo, the EFS at 36 months is 84.5% versus 76.8% That is delta in EFS reads around at 3 years is 7.7%, which is hazards being 0.63 and statistically significant difference in terms of event-free survival rates at 3 years with the addition of pembrolizumab to the chemotherapy. And when you look at the distant EFS events, so the 50% of the first events were distant events and 12.8% with pembro plus chemo versus 20.3% with the chemotherapy alone. So when we look at PCR and EFS in patient subgroups, so the node negative and node positive, if you have a close look, in the node negative PathCR's delta PathCR with pembro and without pembro is 6.3%, whereas in node positive population, delta PCR is in the range of 20.6%. That is, the addition of pembro may negate the negative impact of the node positive disease. So that's what we are trying to correlate here. But definitely there was benefit in node positive and node negative patients, despite the larger relative PCR benefit for the node positive patients. And when you look at PD-L1 positive tumors versus PD-L1 negative tumors, so there was definitely benefit for pembro plus chemo in both PD-L1 positive and PD-L1 negative. If you look at the delta here, in PD-L1 positive, it is 14.2% in PathCRs and 18.3 delta PathCRs in the PD-L1 negative population. So both the population there, that is PD-L1 negative and positive population, had the benefit with the addition of pembro to the chemo. And when you look at the EFS by PCR, so definitely PCR confers good prognosis irrespective of immune checkpoint inhibition addition or not. So that's what we can see here. In the patients who had PCR, the EFS rates with addition of pembro was in the range of 94.4%. And in those patients who had PCR without pembro addition, the EFS rates were 92.5%, that is delta being 2% here. So in the patients with PCR, definitely EFS with PCR after pembro better than in patients with PCR without pembro, hazards ratio being 0.73. In the similar way, if you look in patients with residual disease, that is non-PathCR patients, so EFS is definitely better with pembro than without pembro, hazards being 0.70 and EFS rates being 67% with pembro versus 56.8% without pembro. So
sorry for intervening, you have 1 minute left.
Yeah. The key question is whether we can reliably identify a group of patients who achieve PathCR with chemotherapy alone. So the adjuvant pembro, the trial cannot answer how much the neoadjuvant or adjuvant phase contribute to the overall outcome. And when you look in non-PathCR patients, we don't know, in the absence of trial data, decision about combining adjuvant pembro and capecitabine or olaparib to be, it has to be decided based on the individual discussions because we don't have the data for the combination of the same. And when you look at the treatment-related adverse events, no new safety signals were identified and AEs were consistent with the known safety profiles. Immune-mediated adverse events, definitely they are mostly occur during the neoadjuvant phase with a very low incidence during the adjuvant phase. And mostly they are all low grade and successfully managed with the standard measures. So basically, neoadjuvant pembro plus chemo resulted in a statistically significant and clinically meaningful increase in the PathCRs and clinically and statistically significant improvement in the event-free survivals. There was a favorable trend for overall survival in the pembro group. Follow-up is ongoing. And based on this data, US FDA has already approved pembro in combination with chemotherapy as neoadjuvant treatment and then continued as a single agent as adjuvant treatment after surgery for the treatment of this high-risk early stage TNBC. With that, I'll conclude and I thank organizers for giving me this opportunity. Thank you.
Thank you so much, sir. Moving on, I invite Dr. Rahul Sood, Consultant Medical Oncologist, Command Hospital, Bangalore, to join us for the next talk. Welcome, sir.
Right. Thank you. Thank you to the organizers. Thank you, Dr. Nikhil, for this opportunity to speak. And thank you so much for giving me such a tough topic that I had to read 4 times before I could finally make ends meet. So my talk is regarding circulating tumor DNA. Give me a second, my slides are loading. So I'll try to be on time, but please do let me know. So my study is, let me make it full screen, is regarding the primary result from the C-TRACK trial. And what this trial wanted to do is they wanted to utilize the circulating DNA mutation tracking and see the minimal residual disease, detect this minimal residual disease, and as soon as once you detect this minimal residual disease, you trigger an intervention in these cases of triple negative breast cancer. So a very nice concept, but how they went about it. So then we know about the triple negative breast cancer. They get treated, but they relapse very fast. In the first 2 years are very, very important, because that is where they relapse very fast. So if we detect circulating tumor DNAs in such individuals, these are probably the telltale signs that the patient.
Sorry for interrupting. Your slides are not moving. You need to reshare.
I don't know. I can see my slides. Is it? They're not visible?
Not moving, sir.
Not moving. Okay.
Yes.
I think they're moving. Okay.
No, sir. Please again share. So please share. Sir.
Okay. Right. Okay. Not moving yet.
No, sir.
Okay. Fine.
Can you share from your side? I think the backup team. Is it possible?
Yeah, I think you can share from your end. I think you have my slide deck as well. Right. Thank you. Can you? Right. So let's go to the second slide. Yes, third slide. Right. So next slide, please. So this was a trial design. They studied the early triple negative breast cancer who had received neoadjuvant or underwent primary surgery or completed surgery. So the entire gamut of patients. And they did the circulating tumor DNA, which I still feel probably something still evolving, and how reliable it is not known. And in case active circulating DNA was found to be positive, and this they did every 3 monthly for until 12 months. And in case it was found to be positive, they randomized these individuals as high risk, moderate risk, and a set of it that is went into intervention. That is pembrolizumab, 200 milligram IV Q3 weekly, something which is being used all over left and right. Pembrolizumab, barring the cost, and the other part was the observation. Next slide, please. So this was the method how they did it. I'll skip the first 3 lines because this is what they did in the lab. But the circulating DNA surveillance was done every 3 monthly for 12 months. Yes, COVID came in between, and probably the analysis was slightly skewed. Next slide. And they wanted to register 200 patients. They settled with 150, and out of which they then were able to analyze a number of patients, which were 40. Next slide, please. Could we go to the next slide? Yeah. So the COVID, I think, caused problems. Next slide, please. So the co-primary endpoint was to detect the circulating DNA, because that was the marker. And also the secondary endpoint was what was the time of detection of the circulating DNA. And once it was detected, to give the intervention in the form of pembrolizumab. Next slide, please. So ultimately, there were 208 patients, out of which 77 were high risk. These were the neoadjuvant chemotherapy patients who had residual node positive disease or primary surgery in whom which was done, and tumor was more than 5 centimeters, node positive disease. The moderate risk, which is very important, we need to know who are the high risk and the moderate risk, for the neoadjuvant chemotherapy, where the residual invasive disease was there in the breast and the node was negative. The other was the primary surgery was done where the tumor was more than 2 centimeters or axillary macroscopic lymph nodes were done. So 208 went down to 171 patients. And this is how they divided based on the definitive surgery, grade, tumor size, nodal status, chemotherapy, and equally almost divided the high risk and moderate risk. Next slide, please. So the circulating DNA surveillance results were as follows. The median follow-up was 20.4 months. Yes, there were problems with COVID, so they lost few patients. There were delays. And as you can see, the circulating DNAs in all patients and the split between the risk patients. And as you see, in the high-risk patients, the presence of circulating DNA was more as compared to the moderate risk. So what this says is the circulating DNA will definitely be present in the high-risk patients. So point number one. Number two, next slide, please. Also, out of the 45 patients, 32 were allotted the pembrolizumab arm. Majority of them declined. There were 9 patients ultimately left, out of which 4 declined treatment and 5 were started on treatment. So what is important is the number of patients who received pembrolizumab was only 5 out of the initial. But what is important is 45 patients were detected to have this ctDNA. Next slide, please.
Sorry for interrupting. You have 1 minute left to conclude.
Sure, I'll finish. So this was a treatment group. 4 out of 5 patients, 3 had recurrences. So once again, important marker. 1 had adverse event. Next slide, please. This was a safety profile. Yes, not a very friendly drug. We know pembrolizumab especially. So diarrhea was there, grade 3, enteritis. And remember, these are only the 4 patients we're talking about. So all of them had side effects. Next slide. In the observation group, the lead time for progression was 4.1 months. And this is very, very important that out of the 9 high-risk patients, there were 7 recurrences which happened. So once again, you see the individuals who were detected to have ctDNA, they relapsed very, very fast in the high-risk groups. Next slide, please. So a lot of crisscross lines, a lot of confusion. But what it all said was, the ctDNA is probably a marker of the future. Yes, we need to study it in high as well as the moderate risk group. Next slide, please. And very, very important, the green line is for the high risk and the pink one for the moderate risk. The high risk start to present them immediately, whereas the moderate risk takes time. Next slide, please. So these are the factors which contribute to the high metastatic rate, and we discussed it initially when we discussed about the high and the medium risk group. Next slide, please. So conclusion, the first study for circulating tumor DNA for TNBCs, yes, more studies are required. Whether pembrolizumab is the way to go forward in breast cancer, I have my doubts yet. I feel IO still does not hold its potential in breast cancer. Last slide, please. So take home is, yes, ctDNA testing should start early. We need markers, but which are reliable tested markers in India. False positivity is still high. ctDNA should start in triple negative breast cancer once validated, even during adjuvant capecitabine. High risk patients are the ones who should be closely monitored. Over time period, we need more studies and more robust data in triple negative breast cancer, and probably better screening methods. The ctDNA is probably the start. Thank you very much.
Thank you so much, sir. For the next talk, I invite Dr. Bharat Patodia, Consultant Medical Oncologist, AAG Hospitals, to join us. Welcome, sir.
Thank you very much. Can you hear me?
Yes, sir.
Yeah. Mr. Aram, will you be displaying my slides or shall I host it from my side?
You can share your slide.
Okay, give me a second. I know we are running late. Yeah. You have to make me. Okay. So thank you very much to Dr. Nikhil sir for giving this opportunity, and I'll just begin my topic. So my role is to cover PARP inhibitors in germline BRCA1 and 2 mutated breast cancers. So there are 3 settings: adjuvant, neoadjuvant, metastatic settings. So first thing which I'm going to focus in the 10 minutes is the Olympiad, which is focusing in neoadjuvant and adjuvant setting. So what they have done is based on the germline pathogenic BRCA1 and mutation, done on the local testing at MARAD, and they subdivided into HER2 negative and triple negative, stage 2 to 3. So they have subdivided into neoadjuvant and adjuvant. In neoadjuvant group, further division of TNBC who achieved non-pathological CR post-chemotherapy exposure, or hormone receptor positive which have a non-pathological CR of more than 3. So this is post 6 cycles of neoadjuvant chemotherapy, followed by surgery, followed by radiation, and then they offered olaparib. In the adjuvant subgroup, they included a TNBCs which is more than PT2 or have a node positivity, or hormone positive which are more than 4 lymph node twin positive. So surgery done, 6 cycles of chemotherapy, radiation, and then olaparib or placebo. So 1:1 randomization, and the primary endpoint was invasive disease-free survival with important secondary endpoint of distant disease-free survival or overall survival. So there were further stratifications like hormone positivity adjuvant and what concurrent adjuvant therapy they were given. So there were some statistical assumptions like the hazard ratio they kept 0.7 to be significant favoring the olaparib, and they have included a significant number of 1800 participants. The IDFS superiority boundary was kept at a p-value of less than 0.005. So what we what we found out from this is this is the data released in December 2021. The intention to treat population. So there was a significant improvement in olaparib arm following the adjuvant or neoadjuvant settings versus the placebo. So this benefit was at the 3-year of analysis. And the type of first IDFS was the olaparib arm was only 72, while the placebo arm it was 120. So distance CNS recurrence was 22 in the olaparib, while the placebo it was 36. So whatever the IDFS we see, the olaparib arm it is less compared to placebo arm. Now in Olympia, the overall survival did not change much initially, though at the end of 3 years there was a difference. So 3-year survival is a 3.7% benefit, while at initial 1 year not much. While if you compare the distant free survival, then the curve starts separating quite early, whether we do it interim analysis at 3 years, 2 years, or 1 year. Now, there were few side effects, summary of adverse effects. The serious adverse effects were actually lower than in the olaparib arm, and the main side effect being the nausea, which is quite manageable. So we see that adverse effect leading to permanent discontinuity to arm was in olaparib definitely more than the placebo, but the serious side effects were not so much. Now there was an interim analysis released in 2021 in which that was interim analysis at 2.5 years, in which there was they have favored the heterogeneity, the significance. If you see on the right side, the p-value did not achieve the significant value, but this subgroup analysis was not I'll say key not to be taken in the consideration in the because the significant main effect in the hazard ratio was a different conclusion for a subgroup analysis. So it should not influence the interpretation of the main effect and the intention to treat population. Now there were similar studies like JPAR-OLA studies, which was a phase 2 study, not a phase 3 study, which assessed the efficacy of paclitaxel and olaparib in comparison to pacli-carbo followed by EC as a neoadjuvant chemotherapy arm in HER2 negative early breast cancers. So so primary endpoint for this study was if pacli olaparib followed by EC versus pacli carbo followed by EC. So pacli olaparib had a higher pathological CR. So this is a hypogenerating study, not a phase 3 study, which we can change the paradigm changing. So now another similar paper, the event-free survival. So what this paper suggested is not all PARP inhibitors are same. So this this brightness study studied the veliparib And what they studied is the addition of veliparib to paclitaxel carboplatin had not changed anything. So at 4.5 years. So we cannot conclude that all the PARP inhibitors are similar. At present, the olaparib has shown to be beneficial. So EFS, and I will not dwell on this PARP inhibitor because it is not available with us. But this has shown that in advanced breast cancer or metastatic disease, talazoparib has proven its role. Now, keynote 522 already covered by Dr. Venugopal, but that is going to add confusion to our treatment options, because now this study has also shown a significant benefit that adjuvant pembrolizumab versus placebo, the event-free survival is 84% versus 76, significant. However, they have not subdivided into BRCA mutation based stratification, so we cannot do a cross-trial comparison. Now, coming to my conclusion for this Olympia studies is whether we are aiming IDFS or distant disease-free survival in a germline BRCA1 or 2 high-risk HER2 negative patient, olaparib has given a benefit in except the overall survival, PFS or this IDFS or DDFS, it is there. So based on this, guidelines have started accepting it into the guidelines like St. Gallen's. At present, NCCN is not approved yet. So there is a promising data that olaparib can be platinum substitute based on the JEPAR-OLA in a neoadjuvant setting. And with key 52, there are some questions coming up, like what will be the efficacy of chemo plus PARP in an adjuvant setting in non-pathological CR patients. In a neoadjuvant settings, chemo plus immuno followed by maintenance immuno, are they better by neoadjuvant chemo followed by PARP inhibitor maintenance? So whether we are going to pembro maintenance or olaparib maintenance, and of course with immunotherapy, financial implications are there. With this, I will rest.
Thank you so much, sir. We'll be having a panel discussion now. I request Dr. Vamshi Krishna, Director of Medical Oncology and Hematology, AIG Hospitals, Hyderabad, to join us to moderate the panel discussion. I invite Dr. Bhavesh Poladia, Consultant Medical Oncologist, Sangam Cancer Center, Namakkal, Dr. Vinayak Makar, Professor and HOD Medical Oncology, Ramaya Medical College, Bangalore, and Dr. G. Sadashiva, Additional Professor and HOD Department of Medical Oncology, NIMS, Hyderabad, to join us as a panelist. Welcome, sir.
Good evening. Can I go ahead? Can I start?
Yes, sir.
Yeah, okay. Good evening, everyone. And as Dr. Nikhil has told me, I'm going to be showing you the view from the trenches, and then we will see what we'll do on Monday morning. That would be the theme in the next 15 minutes or so. We are running late. I'm actually running late for another meeting, but I will try to cover these 3 abstracts which have been given. And I have a great team. I have got Dr. Sadashiva and Dr. Vinayak to lead me and help me deal with these 3 abstracts. I would also request Dr. Venugopal to join me if possible for the initial trial. This is the first paper, Keynote 522, study of neoadjuvant pembro plus chemo followed by placebo plus chemotherapy. And this was the event-free survival which came in the SABCS, right? Now, this is the original trial which was presented. As you can see, you're using the newly diagnosed TNBC. So first off, Vinayak, this is what they have used as their definition of early TNBC, okay? TNBC either T1C N1 N2, T2 to T4 N0 N2. Now, in my clinical practice, I can't think of anybody who doesn't fit into this group. What about you?
Yeah, it fits into the practice. Most of them are advanced, actually, not positive.
Exactly. So I'm not sure you should call it T4 TNBC as an early breast cancer or an N2 for that matter. Dr. Sadashiva, sir, what's your thought? In our clinical practice, you know, all the non-metastatic TNBC would probably fall into this group. What do you think?
Yeah, yes, you're right. You're right, actually, doctor. Yeah,
so
because
in other
we'll
words,
see something once. Yeah, correct. You're right. Yes.
Yeah. So, you know, why it is interesting for me is, though, you know, you included all this in the paper itself, they had 50% node positive and 75% still remained stage 2. So essentially, though they were supposed to include everybody, the trial has kind of designed itself in such a way that they try to take an earlier patients and maybe to see a better result, perhaps. So that's what I could think of. Dr. Venugopal, if you're there, what's your thoughts on this chemo combination? Is paclitac, is carboplatin a standard now for all of us, or is there still some debate about this?
No, sir. I think I don't think we have. I mean, it is standard of care, but we have not, included as a standard of care in practice for all of our patients. That's what I feel. So, pacli-carbo combination is not being followed as a standard of care for all of the patients. That's what I feel. Definitely.
Okay, Vinayak, what's your thought? We keep discussing carboplatin. I think since you and I joined DM, we have been having this debate about carboplatin in.
My thesis topic was platinum in triple negative breast cancer. So,
fantastic. So you can tell me, should it be the standard of care for all of us?
The data is not very clear as of today.
Okay.
We're in the same situation. I think we'll forget about it eventually.
Perfect. So again, the reason I'm bringing out all these issues because this is what we can look at as the conclusion, and this is what has been used in the other trials as well. Right now, this is the study endpoint: pathological CR, EFS. Dr. Sadasiru sir, you are a senior person. By dint of all your experience, is PATCR really the right thing you should be chasing in a trial where you're going to be giving neoadjuvant and adjuvant for 1 year? Is this the right endpoint?
I think over the 15 years, I think what you said is over the 15 years, we're still debating on the PCR, whether it is surrogate endpoint for overall survival or not. So, but I think still people they'll consider the PATCR is still, because problem here, we have so many agents to tackle the relapses or something, any events. With that, we are unable to come to a conclusion this overall survival is the end point of many of our trials. So whatever we see nowadays, all those trials, they may not show any overall survival benefit, but definitely we'll find something event-free survival or disease-free survival. I think still, as you said, so because the people, they wanted to have the early results, so PATCR as a surrogate endpoint, everybody they are accepted. We are also accepting that one. But I think, as I said, it still debate is going on.
Vinayak, you agree with that? EFS and PATCR both are better at least than only PATCR, especially in a trial where you're going to be giving an adjuvant pembrolizumab for close to 1 year.
So there is another complexity there. They are using a co-endpoints,
Correct.
So there are statistical methods which we not very clear as a practitioners. So I think EFS is a good endpoint for adjuvant, which are either neoadjuvant or adjuvant. PATCR, I have my own doubts, but EFS I'm okay.
I think I'm in your group. I am not a huge fan of the PATCR. But now look at the EFS. A difference of around 8 to 9%. Is that sufficiently good enough for you, Vinayak, to tell that, yes, let's recommend this drug for everybody? Remember this EFS and your confidence intervals, remember, 0.48 to 0.8, a little wide, and hazard ratio 0.63. Sufficiently good for you? You're satisfied with this?
It's significant. That's all. Whether it's practice or changing or something, it's only time will tell.
Gopal, your thoughts? Sufficiently strong enough hazard ratio for you?
Yeah, I mean, if you look at statistically, yes, definitely it is significant by p-value.
Okay.
And yeah.
All right. See, again, look at the curves. For almost 9 to 12 months, they don't really separate much. It's only after the 1 year that they start separating. And probably that's where, you've stopped, you're continuing your pembro, but you're not giving any other thing in the opposite arm. Is that the reason why you're seeing this arm separating and then staying away? I mean, that's just a thought. Dr. Sadasiru, what do you think?
Yeah, I just said something because we are not giving anything in the opposite arm. Whether there's a BRCA positive or something, whether any other therapy also, we are not just looking for that one. So I think, as I said, yes, something entered some issues are there, but only problem here is the p-value is so much significant. So it is, most of people, they'll think that it's 0, 0, 0, 0. So with that is the only one thing. But I think, there's a problem is going on. Yes, you're right.
Okay. Dr. Vinayak, Dr. Venugopal, you presented this study. 5 sensitivity analysis, all doing different things. I mean, you're just complicating the whole trial, the good old days when you had 2 arms and you said one is superior to other on basis of OS. This hierarchical testing, sensitivity analysis, is it distract you from the actual results? What do you think?
Exactly, sir. Actually speaking, because we are just starting with neoadjuvant immunotherapy, neoadjuvant followed by surgery, followed by continuation of immunotherapy, I think they have decided the study design to be like that, because we are, I think for the first time we are using in that setting. So I think they have included so many variables to pick out enough information. That's what I felt.
Right. Vinayak, again, two subgroups, all subgroups benefit irrespective of what it is. It kind of goes against the grain that you're using such a difficult medicine and you say that it works everywhere. There's no selection criteria. So what do you think after this trial, where would you actually suggest this drug?
I think the clarity is still not there. This is my thing, because I think biomarkers are not very specific.
Right. And you can take the next one also. Thoughts on the A's. We keep saying IO is so easy, IO is so easy. The trials are not that simple. There are patients who get into trouble.
I've burnt enough hands to know that it's not
enough fingers on it. Absolutely agree. Perfect. So that was the first trial. Now I'm just going on to the second trial. The reason being that, it kind of mirrors a few of the things what we saw in the first one. So PARP inhibitors in germline BRCA1, BRCA2. Now this was focused on the Olympia study, right? Now this is the Olympia. And what really struck me was this. They had both the groups. So they included in the neoadjuvant group TNBC, which did not get a PAT-CR. In hormone positive, they also said that they added an extra group. And in this, patients got neoadjuvant followed by surgery. So even if patient did not have PAT-CR after TNBC, they were eligible for this. In the adjuvant group, they again used anything more than T2 or N1, which is practically all my TNBC patients. The only thing is they were having pathogenic mutations. So again, Dr. Sadasiru sir, what do you think? Is it a very broad inclusion criteria? We are effectively taking every patient other than those who get a PAT-CR.
I think the same thing I wanted to apply to the previous study also.
Yeah.
I think they are including many subgroups. Maybe they will expect one benefit in one arm. So they'll enter subset analysis. They'll say that this group is good and they can use it. I think problem is the designing. I think they are a very broader way. I think they'll try to dig only one point and ultimately, so they'll conclude that this subset of the population, because again they'll mention this is a primary endpoint only. It's not a secondary endpoint. Something they'll only for the convenience sake these people they are using. I don't think so. So many ups. Yeah. Yes.
And again, look at the primary endpoint, invasive disease-free survival. It's practically the same as a EFS. I mean, hair splitting, we can find a difference between the two, but practically the same thing. Now, this is the overall survival arm. And look at the hazard ratio of 0.68 with crossing the unity, 0.024, not the 0.00 thing that we are accustomed to. Dr. Vinayak, what do you think of this OS? Is it something that makes you confident or happy, or?
I think we need more time. Second thing is it is not the primary endpoint. It was secondary endpoint. So I would not really go into it.
So a 3-year survival rate of 3.7% difference only. And for that, using a drug like olaparib for 1 year, what's your thoughts? Would you think that's justified? Okay.
I would have not very happy with 3%, but affordability is the issue always with that. So it will always rule out that 3% also.
Venugopal, Olympiad has not shown any OS benefit in the metastatic setting. Your Olympia is not showing any benefit in the overall survival in the early stage or whatever the early stage is. Do you really think that this should be become a standard of care? Venugopal, you're there? I think Venugopal logged out when I stopped talking about pembrolizumab. Okay, he is a one-man army. His target today was pembro and he decided to talk only on that. Dr. Sadasiru sir, your thoughts?
Yeah, I think the problem is, again, the statistics is very, very big problem to how to interpret that one. If you take something about breast cancer, the overall, the paclitaxel overall survival benefit is only 3%. You can imagine that. So I think that people are still there have accepted that the paclitaxel should be the part of it in your treatment now. So here also we can see the 3% now. Problem here also we can see 3.7%. So problem is the statistics. I think the interpretation and how do you? I think you said how do you practice on Monday? It's very difficult now.
Right.
I think
will ask you at the end.
Yes, and Dr. Vinayak said I think better we can wait for some more data. And again, as you said, if overall the EFS is better, but again the overall is a little bit under. We have to just wait for some more data.
Again, adverse events, I think all of us, whatever the study might say or the charts might show, agree that compared to a placebo, definitely olaparib will have more side effects. I don't think this slide we really need to discuss more than that. Again, subgroup analysis. Now, Dr. Bharat did show this is what the audience said, what the author said, that thanks to statistics, even though there is showing some groups do not show benefit, we should completely ignore that subgroup. Dr. Vinayak, what do you think?
I think
buy that argument?
I don't buy that one, because it's more confusing. So things are confusing means they're hiding something. I want to know what is the hiding.
Especially the platinum, because remember this was again a paper on the brightness. Again, updated analysis came this time, and you saw that if you had given carboplatin, it didn't really make any difference whether you added veliparib to that or not. Whatever benefit had to come from the carboplatin itself. There was really no extra added advantage of putting veliparib into it. So again, I'm not really sure how much benefit olaparib or something is going to do in this group. So these were my doubts, and again, I think the panelists are also as confused. And last question, this has also been asked in the panel. Dr. Vinayak, how do you integrate IO with olaparib? Would you give neoadjuvant pembro, patients who are germline BRCA, then switch them to olaparib? Do you want to combine the two? What's your thoughts? Both
I would,
future
I would,
and present.
I would choose one of them actually at one time.
Okay.
Either I think the pembro data is a little bit clearer than olaparib data. There is an element of doubt, and there is element that you said. The platinum almost the same job of PARP. So if I use the IO combination with the carboplatin, I should get the same benefit.
Fair enough. Okay. Dr. Sadasiru sir, what do you think? Integrating IO with?
I think frankly speaking, the IO therapy with my experience is very, very bad, frankly. So the allowed single agent also, just I think if we have some trial or we have something is going on, I think not that great. So I can't, even we are struggling to give the single agent. I think the combination chemotherapy, combination with olaparib, it's of course I'm practicing in a government setup. I think it's add some more financial toxicity also. That was it. So I think at this moment, I think we'll wait. I think I can't.
So the next one is the CTRAC study. Now the CTRAC study was basically interesting for me till again I saw the thing. Look at the early stage triple negative neoadjuvant residual disease, primary T2 or node positive. So I think Western people have taken it that all TNBC in India are going to be early TNBC, because that's what the inclusion criteria in all studies across groups seems to be. Now, what do you think, Dr. Vinayak, of this? Don't give anything. Don't give pembro before. When you randomize, and if they have a positive ctDNA, give pembrolizumab as an intervention. I mean, where does that come from? Where did it come out of left field that you give pembrolizumab for a ctDNA positivity? No chemotherapy, nothing else. I'm confused.
I think they're hinting that immunotherapy is not a good drug to use alone or anything. It's only capable of taking care of MRD. Seeing the data, I don't think it's worth even MRD also. So.
Okay. Very good. We will see that data, because remember, at the end of 1 year, 27% patients were positive by ctDNA, of which 72 were positive by staging. In other words, 3/4 of the patients who anyway were positive on ctDNA, you would stage and get them positive as well. So that's how it showed. Dr. Sadasiru, does this correlate with a clinical experience that 20% of our patients are positive on imaging at the end of 1 year? Is it that bad TNBC in your practice, or is it slightly
No, not that bad. I think
not that bad.
Definitely is not. Yes. I think still we have seen many patients that they never have that type of
So again, the multi-brilliant question: what about olaparib maintenance? Can we use ctDNA in those patients? I don't think we know the answer. Now, this is the author's conclusion, where the only thing which I actually agree with them is that maybe if you do a ctDNA early, you might possibly get earlier detection. But beyond that, I don't know how it really helps. Again, they have themselves said that highest risk patient may not be appropriate for surveillance alone. And they've actually said that even during capecitabine, if you're giving adjuvant, consider using ctDNA surveillance. So that's about it. Right, my last slide. So coming for a Monday morning, Dr. Vinayak, TNBC, T2 and node positive, would you give neoadjuvant pembro? Yes, no?
Yes.
Yes, very good. Dr. Sadasiru?
Yeah, I said no. Yes, but the problem
yes, okay. I would say no. I am not giving it. I would not give it to the patient.
Yeah.
You are saying both of you yes, you're both better. Okay,
correct.
great. Germline BRCA testing upfront, yes, no?
Yes. Triple negative, yes.
Yes.
Yes. Here we are all in agreement. I will
Triple
also
negative.
Okay, if germline BRCA, would you give pembro? Yes, no? Vinayak?
No.
No. You said first one to everybody. Okay.
I will not make decision based on the BRCA. I'll make decision independent of it.
Dr. Sada, if germline BRCA, yes to pembro, no to pembro.
What is it?
Yes. Okay. No to pembro. Okay. Olaparib for PAT-CR. PAT-CR, would you give yes, no? Dr. Vinayak?
No.
No. Dr. Sada?
No, no.
Things are easier because this was not included in the trial, so we're happily avoiding olaparib in that group, which is something that people did ask. So even if you get PAT-CR and a germline BRCA, we don't know, but probably would say you can avoid it. Very good. So CTC monitoring, yes, no. Dr. Vinayak?
Yeah, I don't know the cost part, but it definitely is a good one.
Yeah. Okay. Dr. Sada, yes, no. CTC monitoring.
No.
Very good. So interesting debates we have, and again, as usual, all the trials, none of them have really. I think the Pembro trial is one which is thought-provoking. It's something I offer. I'm not giving it to everybody. Olympia again. I think okay, we kind of lost you, sir. Okay, so my own conclusion, Pembro, yes, probably. Germline BRCA, I would offer olaparib for a higher risk, not for somebody who has developed a good response to chemotherapy and one who has used platinums already. CTC monitoring, we still have a way to go. So thank you very much, and over to the organizers.
Thank you so much, sir. That was a wonderful discussion. With this, we conclude our second session. We move on to the third session. This session is sponsored by Novartis. This will be a panel discussion. I invite Dr. Sudha Sinha, Clinical Director and HOD, Medical Oncology Care Hospital, Hyderabad, to join us as a chairperson. To moderate the session, I invite Dr. MBT Krishna Mohan, Senior Consultant Medical Oncologist, Basavatarakam Indo-American Cancer Hospital. I invite our panelists, Dr. Rajesh Bholam, Senior Medical Oncologist, Yashoda Hospital, Hyderabad, Dr. Rajani Priya, Consultant Medical Oncologist, Mahatma Gandhi Center, Visakhapatnam, Dr. Rekha Bansal, Consultant Medical Oncologist, Apollo Hospital, Hyderabad, Dr. Vindhya Vasini, Consultant Medical Oncologist, Omega Hospital, Hyderabad, Dr. Sadvik Raghuram, Senior Consultant Medical Oncologist, Medicare Hospital, Hyderabad, Dr. Shrikant Boga, Consultant Medical Oncologist, Omega Hospital, Guntur. Welcome, everyone.
Good evening, everyone. And thank you to Novartis for this session, and especially to Dr. Nikhil for organizing this. I think we're already running late, so I won't give any big introduction. It's a very relevant topic of CD4/6 in women of all ages. I'm assuming we are talking about premenopausal, postmenopausal, elderly women, and neoadjuvant, adjuvant, and metastatic settings. So I will pass the baton on to Dr. Krishna Mohan to start the panel discussion. Over to you, Krishna Mohan.
Thank you, ma'am. Thank you, Nikhil. And without any further ado, let us start the discussion. So we will, what we will do over the next 20 minutes is to some specific situations and specific scenarios. I will be projecting, requesting the names of the panelists also. Please kindly unmute yourself and then discuss. So all of us know that we are in an era where the hormone receptor positive, HER2 negative advanced breast cancer is going to one of those kinds of a chronic disease which can be managed over a longer periods of time without giving any chemotherapy. So I think all of us, for this first question, that do we think that the treatment paradigm is rapidly evolving? I would say yes. I think all of you would agree with me the same thing, because we know that the endocrine-based therapy coupled with CDK4/6 inhibitor therapy had definitely brought a sea change in the way we manage these patients if you look into the past 5 to 8 years of our practice. So doctor, my first question or first comment is, I request Dr. Rajani Priya to comment on, so would you still use or think of chemotherapy in the first line ER positive, HER2 negative metastatic breast cancer? If yes, when do you do it? Dr. Rajani Priya.
Yes, sir. So in majority of the patients, I will go with the hormonal therapy. Only in a very small subset of patients, that is patients with visceral metastasis, who are in visceral crisis. So we all know the definition of the visceral crisis, sir. So it's not the mere presence of the visceral metastasis, it's a visceral compromise. So only these patients need immediate reduction of the symptomatic rapid responses and rapid reduction of disease burden. So in this subset of patients, only I will consider with chemotherapy. So rest all patients, I'll go with the endocrine therapy. Hormonal therapy with or without CDK4/6 inhibitors.
So okay. So do you think even in visceral crisis, what do you think is the average time for response in these patients? If we do CDK4/6 inhibitor with the aromatase inhibitors or something, So the average response, the time to response is about 6 to 8 weeks. And that is what we expect even for a chemotherapy also. I think even in visceral crisis, I think not everybody with visceral crisis would be a candidate for chemotherapy. But then, as you rightly said, yes, we do consider very selected group of patients who would qualify for chemotherapy in this group of patients. So I think
all the trials, yes, all the trials had taken visceral metastasis, but visceral crisis, like most of the trials, doesn't include patients with visceral crisis, sir.
Sure.
So,
any difference of opinion by anyone, or we'll move on to the next setting? So the treatment goals for, I think all of you would agree with me, in a metastatic breast cancer, mentioning across all age groups in metastatic breast cancer is as the Anne Tannock's way of method of thinking, that maximizing the symptom control, extending the survival, meaning the prolonging the overall survival, and then the quality of life. I think these three are the very important pertinent points when we look at metastatic breast cancer patients, giving them some kind of a treatment also. So Dr. Rajesh, can you please comment if there are any challenges which you face in treating especially the younger patients, premenopausal, hormone receptor positive, HER2 negative patients with an advanced breast cancer?
Sir, in general, the younger women will have a poorer prognosis by age itself, and they do have got the majority of the times greater symptomatic burden. Apart from these treatment-related aspects, the other aspects which come into factor, especially when we are dealing with the premenopausal young ladies of reproductive age group, is like fertility issues and cosmetic issues, hair loss, and multiple things, especially when we see in a advanced breast cancer, where we previously used to give chemotherapy. Now with the advent of CDK4 inhibitors with hormonal therapy, I think this part can be taken care of.
Yeah. Anyone else? All of you would agree with these challenges, or any particular challenge that you are thinking of? So that is what Dr. Rajesh was mentioning. The higher risk of relapse or death and symptom control is important, and quality of life issues are all, these are the issues which we face not only with the older women, but also with the younger women. And Dr. Rekha, so all of us, we do believe, or we have been taught in clinical medicine, that especially in oncology, that the overall survival in a metastatic setting, if some treatment prolongs overall survival, in fact, if you're calling some treatment as a good treatment, it should ultimately lead to the overall survival prolongation. And at the same time, the quality of life should be maintained. So do you believe that improved overall survival without compromising the quality of life, is it achievable in advanced breast cancer?
yes, sir, certainly. So with the advent of CDK4/6 inhibitors, this goal is definitely achievable. So pending the data of two CDK4/6 inhibitors, we do have OS data with ribociclib, and any treatment should be aimed at improving the quality of life, if not, at least not worsen it. So we do have evidence that with CDK4/6 inhibitors, the quality of life is maintained, and in fact, it was one of the secondary endpoints in Mona Lisa 7, and they showed that in particular domains like pain and fatigue, it fared well, and time to deterioration was prolonged.
So you think there is no challenge or in maintaining the quality of life? Because see, what happens is most of the times when we start this CDK4/6 inhibitors, so how often have you faced, or any of the other panelists can add, how often did you face that there was a serious adverse event and then we had to admit the patient for, let us say, a blood transfusion or management of a febrile neutropenia, or for that matter, the number of hospital visits during which they have to monitor their blood tests and then show you the results?
So, sir, I never had a patient who was admitted with any of the complications, and because most of the patients have my contact number, they don't have to really visit me. They can just share the report, and so they don't. The number of visits is also cut down. They don't really have to visit me, sir. So quality of life is definitely maintained, is what I would say.
Anyone else would make a comment? Okay, see, so regarding the choice, so I also had a question to Dr. Rajesh. So if you can see if some of these patients who present to you for the first time in the first line therapy, So there are there are options to choose. So what would be your approach in choosing the CDK4/6 inhibitor in these patients?
So majority of the times, I go with Ribo. Not that the Novartis is sponsoring the session, but various reasons. One, little less cost, flexible dosing schedule. We have the data of pre and postmenopausal. We have the data with OS, and theoretically we do have the data. It is more selective, and I feel toxicity-wise, it is little easy to manage when compared to other. Even though all the three are relatively safe, except for Abima with a grade 3 diarrhea, I think I can go ahead with the Ribo. One more advantage I feel with Ribo is, especially I have a flexibility of checking with the dose. Like for example, an elderly female with a low volume disease, I wanted to start, I can start with 400 and then escalate or de-escalate based on the tolerance. With the above mentioned reasons, I'm more comfortable with Ribo.
Yeah. So there is one peculiar thing which I am facing, at least in two or three of my patients, is that the patients had symptomatic bone disease and we had to radiate some amount of spine. And in those patients, I am not able to reach the full dose of ribociclib. So is it a similar observation by any of the panelists, or even Dr. Sudha can comment on this?
Sir, it depends on the amount of dose of radiation what we are giving, number of vertebra involved. If it is a single met and the low dose, I think that should not be a problem, I guess. What I feel is, because Ribo, as such, the myelosuppression activity is not so high, I feel, sir. But maybe seniors can comment.
Yeah, I have not personally encountered any major issues with blood counts because a patient has received vertebral radiation. I think it's okay. We can go ahead.
Sure. So, Dr. Vindhya, if you are there, so what about the overall survival in women with advanced breast cancer? So, what is your take when you choose or select one of the CDK4/6 inhibitors with particular reference to the overall survival when you want to offer to your patients?
First, I would check their menopausal status. Do you mean, I didn't get the question properly.
So, do all these CDK4/6 inhibitors, when you're looking at the overall survival, do you think all of them have fared well or with advanced breast cancer?
Yeah. Okay. When we look at the data per se, I think ribociclib has a robust data both in premenopausal and postmenopausal women, and also in the first and second line. And in patients with visceral disease. In a premenopausal woman, I would prefer ribociclib. Then maybe if a patient has some cardiac issues, then my choice of CDK4/6 inhibitor might shift to Abema, or if a patient has some GI toxicities, already existing Crohn's or some GI disorders, then maybe abemaciclib would be avoided, preferable to avoid abemaciclib. But I preferably think, I think that all the three CDK4/6 inhibitors are basically the same. They belong to the same class. So maybe once the data of the other two CDK4/6 inhibitors is out, then maybe all would be equally preferable. But right now, ribociclib outpass the other two.
Sure. So basically, we keep hearing or in all the presentations or all the discussions that the QTC prolongation is longer with the ribociclib and all. So it has been quite some time since all of us are got used to this drug. So is it as, do you think it is clinically a significant problem, Dr. Vindhya, followed by Dr. Rajani Priya?
I haven't encountered any patient with a symptomatic prolonged QT interval. Maybe we are not checking them frequently enough. But otherwise, QTC prolongation is not much of a problem.
Correct. So there is no clinically significant impairment in the cardiac conduction is what all I feel. What do you think, Dr. Rajani Priya?
Yes, sir. I agree with ma'am. So like both ribociclib and palbociclib, so they're well tolerable. I have no experience with abemaciclib, but palbociclib and ribociclib, they have a very good manageable profile, safety profiles. So like I have not encountered any of the patients with a prolonged QT interval. So I think.
So one final question would be, so do you think all these three CDK4/6 inhibitors are the same or they are different?
So I think all are same, but only the toxicity profile. But based on the overall survival data, so we prefer going with the ribociclib. So
yeah, so all cannot be same. No? All men are same, but these are women. One is
only the toxicity profile, sir. So we have to
one
choose based on the comorbidities and the toxicities. So that.
Right. Thank you. So this is what the data says, and this was Dr. Vindhya was also mentioning about the overall survival data in different settings across the clinical trials. So we have data for overall survival, significant overall survival prolongation data for ribociclib across all the subgroups, and of course abemaciclib in the first and second line therapy. In the postmenopausal women with fulvestrant, we do have data. And palbociclib, one is pending. Of course, the other is not reported in these two clinical trials. And the classical approach, if you want to choose overall survival, then I think this is what we do. So regarding adverse events, I think we had some discussion. And Dr. Sadhvik Raghuram, what is your take on choosing the CDK4/6 inhibitors based on the adverse event profile?
So coming to the adverse event, Ribo and Palbo more or less have similar side effect profile, except that Ribo has higher instance of transaminitis, and literature-wise, yes, QT prolongation, but I personally have not experienced any of that. But neutropenia is one common thing among Ribo and Palbo, but Abema is quite different. The amount of neutropenia is less, the instance of neutropenia is less, but diarrhea is one major problem because of which tolerating Abema is becoming difficult. My personal experience, I usually go with Ribo. As Dr. Rajesh Pullam has already stated, the dosing is easier, and there's a lot of data on pre and perimenopausal women. Only in case of any known cardiac events, and that is when I tilt towards Palbo.
So that's what has been mentioned in the literature also, and that's what we see in the clinical practice also, that not of these side effects what have been mentioned, they are not very significant in clinical practice, especially QT prolongation. Also, to share my experiences, I have been a part of this one of these as an investigator in the Mona Lisa studies, and where we had a series of recordings of ECGs for our patients. But as rightly we are noticing in the clinical practice, there is not even a single incidence of clinically significant QT prolongation, which we noticed in the these studies, and patients are still going on the protocols. So, Dr. Srikanth, so your comments on your approach. You have started somebody on CDK4/6. So, what do you do in clinical practice?
Yes, sir. After CDK4/6 inhibitors, and we need to divide the patient into whether the patients are PIK3 3CA mutation positive, wild type, or positive. If if the patients are positive, definitely we would like to go with the alpelisib with fulvestrant, and those who are negative. And I am also nowadays I am sending upfrontly I am sending the PIK3 mutation status, sir. And till now I am sending only 4 cases, and all are came negative. And post progression, and we have to divide the patient depending on the disease burden, whether the patient is in visceral crisis or not. Those patients who are not in visceral crisis, of course, we have to need to go with other endocrine therapies like fulvestrant and other whatever previously we are using, and we need to go with fulvestrant and other options like mTOR inhibitors, everolimus with or without fulvestrant, and at least we have to use two more lines of endocrine therapy. Then only we need to go with chemotherapy, sir.
Sure. So in practice, yes. So when somebody progresses on, let us say, ribociclib with, let us say, letrozole, then the second choice, what do you think? Generally, we switch over to fulvestrant. So is there anybody who thinks that you can continue ribociclib and change it to fulvestrant?
As per data, there is no 3 drugs are nearly equal, sir. There is no particular data on that, and
but there is some data on single agent abemaciclib.
Yes, sir. And the two actually, what I read for one case, I use for one of my case, those progressed on palbociclib, and after that patient developed brain metastasis, sir. So I need to switch that patient to abemaciclib single agent. So right now she is doing well, but I don't know whether it is abemaciclib is per se is very effective against the brain metastasis, but she is doing good right now, sir.
Sure. So these are the, yeah, you're right, Dr. Srikanth, because there are several practical aspects which do come into our practice when we do it. That's why the reason why we are asking. So anyone else has any other thing to offer to these patients? CDK4/6 inhibitors after the progression on CDK4/6? Yeah. So I would now invite Dr. Rajesh and Rajani Priya one after the other. So when do you test? The first two questions maybe Rajesh can take. So when do you prefer to test? And would you test on the archival tissue or prefer on a repeat biopsy at disease progression if you want to look at the PIK3CA mutation? Dr. Rajesh.
Frankly speaking, as the PIK3A mutation is different from the other mutations, it's a stable mutation as we know. So it does not make a difference whether you are doing upfront or at the site or at the time of metastasis, because it is majority of the times it's not going to change like ESR1. And second thing, if I have the information upfront, the sequencing would be little better, because I would not be using fulvestrant in the first line, so that I can reserve the drug fulvestrant plus alpelisib for the second line. But in theoretically this is true, but clinical practice I'm not doing in the first line. With respect to the second question, sir, whether it is an archival tissue or a repeat biopsy, if the archival tissue, meaning majority of the times if my pathologist says it's good enough and it is not too old, as I said, as it is a stable mutation, we can get the info from archival tissue. Suppose if the patient is behaving a little unusual, for example, an ER positive tumor, having a visceral mets, or for example, have a rapidly progressive metastasis, and if I'm getting anyways biopsy to make sure whether it is still ER positive, at that point of time only I'm going with a repeat biopsy. Otherwise, if the clinical profile is in sync with the biology of the disease, and if I have got a proper tissue and my pathologist says it's adequate and okay, then I'm okay to do with archival tissue also, because it's a stable mutation.
Excellent, Dr. Rajesh. Very two important points you made. That is a truncal mutation and tissue also. Dr. Rajani Priya, so would you prefer to use the RT-PCR, or nowadays several NGS are available? Would you do an NGS? And what is the role of liquid biopsy in PIK3 mutation testing? Dr. Rajani.
Sorry for intervening. You have 5 minutes to conclude.
Yeah, I have 4 minutes only. Okay.
So I would just go with testing with the RT-PCR, sir. Routinely, I'm not doing NGS. So the testing of PIK3 mutation also, I'm doing it at progression only. Upfront, I'm not doing. So for patients like who are not if archival tissue is not available, so then I'll go with the liquid biopsy. So many studies have shown that liquid biopsy has shown good concordance with the tissue testing also. So it has good sensitivity of almost 80 to 85%. So if the patient is not willing for a repeat biopsy on progression or in the absence of the archival tissue, so even liquid biopsy can be done, sir. So in case if liquid biopsy turns out to be negative, we can convince the patient for a biopsy and then get the PIK3 mutation testing done. So NGS, I'm not totally doing my practice, sir. So other point I would like to add is for patients, young patients, and for patients who have a strong family history of breast or ovarian cancer or BRCA related malignancy. So even I would like to get a BRCA testing also done in these patients. So as you were asking in the previous question, what all therapies you have in the later lines of therapy. So in case if the patient turns out to be BRCA positive, so in later lines even we can go with the olaparib also in the later lines.
Sure.
So as of now, only RT-PCR testing for PIK3. Yes.
Yeah. So unless they have a very strong family history suggesting BRCA,
yes, that's what in triple negative we have, but yes, sir, like in very small subset of patients. Yes, sir.
So Dr. Rekha, so having given all this, somebody has a PIK3 mutation positive. So what would be your preferred treatment option?
Certainly alpelisib and fulvestrant based on the SOLAR-1 trials. So PIK3CA mutation has a poor prognosis. So though the SOLAR-1 trial did not show OS benefit, but 8-month gain is, I think, good for these patients with poor prognosis.
Sure.
So alpelisib and fulvestrant, sir.
Alpelisib, fulvestrant, I think there is a uniform agreement. If somebody has a PIK3 mutation, yes, that is what all of us would like to do. But then there are some problems with alpelisib, as all of you would agree with me. And Dr. Vindhya, what do you think are the most important side effects? If you had used in clinical practice, you can share your experience also.
Yeah, I have one patient on alpelisib. Strangely, she is a metastatic breast cancer with PIK3 mutation who was started on alpelisib upfront. If she was started elsewhere, and then she came for further follow-up with us. She's an elderly lady, known diabetic, but right now her sugar controls are well maintained. She's on metformin and some other drugs for diabetes management under the care of an endocrinologist. So hyperglycemia, yes, is a most common and well documented adverse effect of alpelisib, and apart from that, maybe if we look at grade 3 and higher adverse effects, then rash would be one of the other adverse events which we need to look at.
Sir, can we request to wrap up the discussions,
Yes,
please?
yes, sure. So, is this Dr. Satvik Raghuram? What do you think about the prophylactic use of antihistamines?
Sir, personally, I don't have much experience with Pluvicto. All my patients are negative. But data-wise, yes, starting the drug prophylactically has reduced the incidence as well as the severity of rash.
So I think because of short of time, though we have 1 minute, I think the organizers asked us to stop. So we are stopping here. So in practice, I think all of us would agree that in advanced breast cancer, ER positive, HER2 negative, CDK4/6 inhibitors with aromatase inhibitor is the first choice. And then when patients progress, we have not discussed about the ESR1 mutations. So we do test for PIK3, and then there are several considerations of testing this and then using this treatment in our clinical practice. So with this, I would like to conclude and then thank the organizers for the time.
Thank you, sir. I thank all the participants and the discussants for the wonderful session. Now we move on to the next session. The next session is sponsored by Roche. I request Dr. P.S. Dattatreya, Chief Medical Oncologist, Renova Soumya Hospital, Hyderabad, to deliver his next talk.
Thank you so much, Nikhil sir, Tarun, and the entire team organizing this excellent CME. And I'm here to talk about improved patient outcomes with next generation HER2 targeted antibody drug conjugates. Next slide. Those are some disclaimers. Next slide. And looking at the outline of my talk, introduction, looking at some TDM1 data, and then the local phase 4 study called as ML29662. And also see how this study fared when compared to global trials, real-world evidence studies, etc. And finally, some conclusions. Next slide. So we all know that HER2 inhibitors like pertuzumab, trastuzumab, and TD1 have now established themselves as standard of care in the treatment of HER2 positive metastatic breast cancer. And TDM1 here spans from first line to second line to third line, depending on the patient's clinical characteristics. By and large, in practice, majority of us tend to use TDM1 as second line treatment or beyond in MBC after an initial trastuzumab and chemotherapy combination has failed. Next slide. ADCs stands for antibody drug conjugates. So unique combination of a target-specific MAB, a stable linker, and a potent cytotoxic agents. The advantage becomes that you can deliver a chemotherapeutic agent to the tumor cells and also improve the therapeutic window of the cytotoxic component. Next slide. So this is a drug by name adotrastuzumab emtansine or TDM1, specifically designed to target HER2 positive cancer cells while sparing the non-cancer cells. We know the antibody Herceptin is well understood, and therefore those PD properties of Herceptin are maintained and retained when it's TDM1. More than that, the stable linker prevents premature release of DM1, and therefore you have nil or minimal systemic side effects. Finally, you are able to deliver the drug DM1 derivative of maytansine directly inside the cell of interest. And there, this drug is able to inhibit the assembly of microtubules, and that leads to apoptosis. Next slide. So TDM1 essentially ends up in having a dual mechanism of action On one hand, Herceptin or trastuzumab does what it should do. On the other hand, by delivering the drug DM1 directly into the HER2 positive breast cancer cell, we are therefore able to get inside the cell a very potent microtubule poison, and that leads to inhibition of the polymerase of microtubules and therefore causes cell cycle arrest and cell death. Next slide. And so the Amelia trial showed that when compared to capecitabine plus lapatinib, which gave median PFS of 6.5 months, TDM1 gave a median PFS of 9.6 months, hazard ratio of 0.650. What about the overall survival? Next slide. TDM1 30.9 months, which was 6 months better than the combination of capecitabine plus lapatinib, with a hazard ratio of 0.68 and a p-value of 0.0006. Now, so I think the hazard ratio of 0.68 should be kept in mind, and the p-value of 0.0006 also should be kept in mind, because the next slide, please. The next trial, TRESA trial, looked at TDM1 compared to treatment of physician's choice. And again, as you can see, the hazard ratio is 0.68 and the p-value is 0.007. So almost overlapping with what TDM1 did in the Amelia trial. Next slide. And so if you look at both these two trials, in second line and beyond HER2 positive MBC patients, Amelia and TRESA established TDM1 as the standard of care. The median OS in Amelia was 30.9 months. The incidence of grade 3 adverse events were lower with TDM1 when compared to the control. Next slide. So this drug has a well-established clinical efficacy and safety profile. It's a part of various international guidelines, and also we have a comprehensive clinical trial experience. If you look at the ESMO MCBS score, the magnitude of clinical benefit score, for the efficacy, it's rated as 3, and then you add 1 because of the quality of life. So +1 is adjustment for quality of life. Ultimately, it comes out to be a score of 4, which means substantial benefit from TDM1 in the treatment of metastatic breast cancer HER2 positive. So the efficacy we know is there, and it speaks for itself. Next slide. We now come to the phase 4 clinical trial looking at ML29662, and this was an Indian study of 70 patients. Next slide. Multi-center, open-label, single-arm phase 4 study in patients who are HER2 positive, unresectable LABC or MBC who have received previously trastuzumab and a taxane. Next slide. The primary endpoints in this study of 70 patients was to look at, is this drug safe, the incidence and the severity of adverse events, and adverse events of special interest like lab results and drug-induced liver injury, to look at the tolerance of TDM1 and how many patients required dose modifications, dose interruptions, or dose discontinuations. Because we know the primary endpoint right now in this study was look at the safety and the adverse events, but the secondary endpoints also did look at the overall response rate, PFS, and the overall survival. Next slide. The first patient in this study was enrolled on 9th of December 2016, and the last patient on 14th of December 2018. Next slide. Looking at the outline of the study from patient disposition to overall conclusions. Next slide. 19% of patients were still ongoing treatment with Kadcyla. 40% of them stopped the drug because of discontinued disease progression. 10% lost to follow-up. 23% withdrew consent, and 14% had died. 3% of them stopped the drug because of an adverse event. Next slide. At initial diagnosis, 44% of patients were de novo MBC. Next slide. But when they entered the study, of the 70 subjects, 20% had locally recurrent disease, 10% had LABC unresectable, and around 80% of them had metastatic disease. ISC was 3+ in 72%, and the remaining 14% ISC was 2 and FISH was positive. Next slide. Multiple comorbid conditions, at least one of them was present in almost 43% of patients with hypertension, diabetes being 37%, 20% respectively, and 13% of patients had hypothyroidism. Next slide. So looking at the safety endpoints, which was the primary objectives of this study, looking at the severity and incidence of adverse events, serious adverse events, looking at CHF and NAB results. Next slide. Duration of study treatment was 40 weeks. The mean number of cycles per patient was 13.24. Next slide. 40% of patients were deemed to be having an SAE, of which 10% of them were related to TDM1. 3% of them were adverse events of special interest, grade 1 pneumonia, which was non-serious, and grade 3 increase of ALT and AST. Next slide. Platelet count did decrease to grade 3 in 3% of patients, and hemoglobin anemia grade 3 in 1% of patients. But let's try to compare the safety profile of this Indian study with the Amelia trial. Next slide. In fact, across various parameters, bone pains, body pains, thrombocytopenia, headache, epistaxis, increased AST and ALT, patients in the Indian study seemed to do better than the Amelia study, whereas more patients had pyrexia anemia in the Indian study when compared to the Amelia study. So more or less, the adverse event profile seemed to be almost the same, with some variations here and there. Important is cardiac safety. And next slide, no cases of CHF were reported during this study. 2 fatal SAEs of cardiac arrest and CRA were reported in 1 patient each, and both of them were thought to be not related to the study drug. Next slide. If you try to look at the mean course of how the LVEF decreased from baseline, a baseline decrease of more than or equal to 10% was not observed at any visit, and all the patients maintained the LVEF above 50% when compared to the when looked at all the post-baseline visits. Next slide. So safety conclusions of ML29662 were: in Indian patients, the safety profile is acceptable. No clinically significant changes in lab parameters and vital signs. The safety profile of TDMN is by and large consistent with the Amelia study. Overall, the review of the safety data did not show any new safety signals in Indian patients. So now we know that the Indian study corroborates with regard to safety, almost like the Amelia or the global data. Next slide. Let's look at the efficacy endpoints. And here you did find some differences. Next slide. In the Amelia study, the overall partial response rate was 43%, which was 23% only in this current Indian study. Then next, 57% of patients had stable disease. Having said that, the median duration of response was 15 months, which was 14 months in the Amelia study. Next slide. The median PFS in the Indian study was 14 months, which was around 10 months in the Amelia study. So the median PFS, despite having lesser number of partial responses, was in fact, though you can't compare, but then it was like 10 months with the Amelia trial and was 14 months with the Indian study ML29662. Next slide. Looking at the overall survival, which was 31 months with TDM and Amelia study, and it had not yet you could not evaluate that in this current Indian study. So to conclude, next slide, TDM1 shows effectiveness in clinical practice, supporting clinical trial data in HER2 positive metastatic breast cancer. Real world evidence for more than 3,500 patients from 12 countries across 3 continents. Now you have studies where they used it at any point of time versus studies it was used in second line and studies in third line plus or beyond, and then the Amelia and the Indian study. The real world evidence of all these studies reinforces the findings from randomized clinical trials, showing that TDM1 is, on one hand, efficacious against the HER2 positive MBC, and on the other hand, also in clinical practice is well tolerated. So these are my conclusions about the efficacy of ML29662. Next slide. It demonstrated beneficial efficacy results with regard to response rates, stable disease, PFS, and OS. The median PFS was 14 months, and in those patients, in those 1 in 4 patients who respond, the duration of response is 15 months. The median OS at this point of time was not estimable, but seems to be around 3 years. Best overall response was of stable disease in 59% patients. The results, by and large, seem to be similar to the Amelia study and collectively show a favorable safety profile of TDM1. So coming to the last slide of my talk, overall conclusion is, next slide, the Indian data, the phase 4 study concludes that TDM1 is safe and efficacious in Indian patients with HER2 positive LABC or MBC patients who have received previously trastuzumab and taxane. The assessment of safety data, which was the primary objective of this study during this review, did not identify any specific safety concern for Indian patients. And so the benefit risk profile of this molecule remains unchanged, be it a randomized clinical trial like Amelia or TRISA or a phase 4 data like the Indian study. Thank you so much.
Thank you so much, sir. Moving on, we'll be having our last and final session today. I request all the presenters to stick to the timeline, please. I request Dr. G. Vamshi Krishna Reddy, Consultant Medical Oncologist and Hemato-Oncologist, Yashoda Hospital, to join us for the next talk. Welcome, sir.
Yeah, good evening. So, can I start the session?
Yes, sir.
Yeah. So I think from what Dr. Dattatreya sir said, like I'll be going on with the next session, which I'll be trying to give a short update of the abstract which was presented at CBCS. So I'll be talking about the Destiny Breast 03 trial, and this is a direct head-on comparison with TDM1. So we have this Enhertu or trastuzumab deruxtecan, which was compared head-on with TDM1 trastuzumab emtansine in patients with the HER2 positive MBC. And this was the subgroup analysis from the phase 3 Destiny trial, which was a multicentric open label randomized trial. And this study had approximately 524 patients, of whom majority of them were unresectable or metastatic HER2 positive MBC, and they were treated at least with a trastuzumab and a taxane. And the taxane use was approved even for those who progressed within 6 months or who progressed on chemotherapy. And the other important thing was they even included patients who had this brain metastasis who were treated at least 2 weeks or earlier with radiation, or who had clinically stable brain metastasis who were not treated. And they were stratified in a 1:1 arm between the TDX and TDM1. This trastuzumab deruxtecan was given at dose of 5.4 milligram per kg every 3 weekly. The primary endpoint for this trial was a PFS, and they had other secondary endpoints like OS, ORR, and PFS also. The baseline characteristics we can see are well divided between both the groups. So the median age was 54 years across both the arms. And we can see that a good number of patients in this trial were from Asia, like almost 60% of the patients from the Asian continent. And the brain metastasis was approximately 23%, which was again balanced across both the arms. And they also had patients who received both trastuzumab, almost was 100%, was 99.6% in both arms, and pertuzumab was received in almost 60%. So the primary endpoint, which was the progression-free survival by the blinded independent central review, we can see that the data cutoff, there was almost 32.2% who progressed on trastuzumab deruxtecan versus 58.9% who progressed on TDM1. So it's almost 32 to 60% who progressed on TDX2. So that's a significant thing which probably happens in the second line setting in MBC HER2 positive. And again, the subgroup analysis, if we can see, the same PFS was across maintained across all the subgroups. So even for those patients who had this hormone receptor positive disease, we can see that irrespective of whether the positive or negative, the PFS was higher in the trastuzumab deruxtecan arm compared to the TDM1 arm. And mainly for those with brain metastasis, we can see that the PFS was very much towards the TDX compared to the TDM1 arm. And we can see the overall response rates and the CR and PR across the subgroups. So we can see widespread. It's quite clear that the response rates were much higher in the TDX arm compared to the TDM1 arm. All across all subgroups, whether the hormone receptor positive or negative, whether they have received the prior pertuzumab-based therapy, visceral disease, and also for those with brain metastasis. Good thing about this TDX was the efficacy which they have demonstrated in those patients with and without brain metastasis. So we can see that those patients who had brain metastasis at baseline, the median PFS was almost 15 months compared to those with 3 months on TDM1. So this is quite significant in the second line setting where the brain metastasis are an issue for us. This is actually a game changer drug for those with brain metastasis. And we can see the response rates across both the arms. We can see that the overall response rates almost 79% compared to 34% with TDM1. The CR percentage is also, it's almost double. We see almost 16% of the patients having a CR compared to 8.7 with the TDM1. And the total disease control rate, which includes the CR, PR, and stable disease, is almost 96.6% compared to 76% with the TDM1. So all these favor the TDX arm compared to the TDM1. And the intracranial response rates, we can see that if you compare between both the arms, it's almost CRs were seen in 27% compared to just 3% in the TDM1 arm, and also the partial response rates were also higher towards the TDX arm. So both this data show that TDX trastuzumab deruxtecan is very good in those patients with brain metastasis. And coming to the AEs, we can see that the majority of the patients who received TDX, they had a longer survival, so they took the drug for a longer time. So we can see the 14.3 months was with the TDX compared to 6.9 months for the TDM1. So comparatively, the AEs were also different. So if we are doing the exposure adjusted incidence rate, it was almost similar across both the groups. But if you are going with the individual treatment emergent AEs, it was a bit higher in the trastuzumab deruxtecan arm. What are the specific effects which we see? Yeah, compared to the TDM1, where we see more of thrombocytopenia, we are seeing comparatively higher neutropenia, anemia, and leukopenia in the TDX arm. And also the GI disorders were higher in the TDX compared to the TDM1. And also we can see that there was significant alopecia, which is not seen with TDM1. ILD is one AE which probably is quite higher in the TDX arm, but there was no grade 4 or 5 ILDs with the trastuzumab deruxtecan, and the AEs were similar even in the Asian subgroup population compared to the non-Asian population. So we have seen more of grade 1, 2, and 3 interstitial lung disease, which needs to be monitored for those patients on trastuzumab deruxtecan. So to conclude, TDX treatment demonstrated consistent efficacy benefit over TDM1 across all the patient subgroups. The PFS, the hazard ratio was almost 0.28, and the overall response rate was quite high. It was almost 80% for the TDX compared to 34% for TDM1. And mainly for those patients with and without brain metastasis, TDX treatment resulted in greater efficacy compared to TDM1. So the PFS for those patients with brain metastasis was 15 months compared to 3 months for TDM1. And we can also see that the TDX treatment is associated with substantial response even in the intracranial disease, and also the reduction in the CNS disease. So we can see that it was almost 28% for the intracranial CR with the TDX compared to 2.8% for the TDM1. And it also demonstrated a manageable and tolerable safety profile. And there was no difference in Asian and non-Asian population for the ILD. So all these data support using TDX as the standard of care for second line therapy. So what I'll be doing with this evidence. So for me, for the first line, I usually go with trastuzumab, pertuzumab, and either any taxane, docetaxel, or paclitaxel based on the patient comorbidities. So this is based on the Cleopatra trial. But what is going to change with this current data is probably we will be displacing TDM1, probably trastuzumab, which was probably in the third line, has moved up the ladder from third to second, and mainly I'll be probably preferring this drug in those with brain metastasis for the response it showed in this Destiny Breast 03 trial. So great thing, it's going to be a game changer in the second line, mainly for those with brain metastasis. Thank you.
Thank you so much, sir. Moving on, I invite Dr. Kripa Bajaj, Consultant Medical Oncologist, Basavatarkam Indo-American Hospital, Hyderabad, for delivering her next talk. Welcome, ma'am.
Yeah. Good evening, everyone. Thanks to organizers for having me here and giving this opportunity. Can I share the slides, or organizers will share the slide?
You can share the slide.
Yeah. Is it visible now? Is it visible? The slides are visible?
Yes, ma'am.
Go ahead.
Yeah. So thank you, sir. So today I'm going to discuss a French study, PADA-1 study. It's a very good example for bench to bedside science. So it has studied fulvestrant plus palbociclib versus continuation of aromatase inhibitor plus palbociclib upon detection of circulating ESR1 mutation in HR positive, HER2 negative metastatic breast cancer. So coming to the background, we all know ESR mutations are like bound to happen in metastatic breast cancer.
Yes.
Afferent in metastatic breast cancer, only we see less than 5% of patients having a ESR1 mutation. But once the treatment got started with endocrine therapy, nearly 30 to 40% of patients will develop ESR1 mutation on progression, especially under AA-based treatment. So ESR1 mutation not only predicts resistance to AA, but also it like suggests a sensitivity to fulvestrant, and there will not be any resistance to fulvestrant or palbociclib. So whenever ESR mutation is like developed, the cells will be resistant to AS, but not to fulvestrant or palbociclib. So ESR mutations, whenever happen in breast cancer cells, the estrogen receptor will restore the ligand independent activity. It drives resistance to aromatase inhibitors, as I already mentioned, and it can be detected by circulating tumor cells. Circulating tumor cells evaluation for ESR1 mutation. So what is the PADA-1 concept? So it is it's not like Pearl study concept, it's a different concept. So the PADA-1 concept is to prevent or delay tumor progression in patients receiving the first line AI plus palbociclib treatment by targeting ESR1 mutation with a switch to fulvestrant as soon as ESR mutation become detectable while maintaining CDK4/6 inhibitor. They haven't removed the CDK4/6 inhibitor. Look at the study design. What are the inclusion criteria? The patient PS should be preserved. The hormone receptor positive status should be more than 10%. So like many of us will not agree with this 10%, but the inclusion criteria is more than 10%. And clearly there should not be relapse under 12 months. There should not be primary endocrine resistance to aromatase inhibitors if your patient received in adjuvant setting. It should be first line. There should not be any prior systemic therapy. The patient should have adequate organ function without any visceral crisis, and she should have a evaluable disease. So when it includes both postmenopausal as well as premenopausal, and the premenopausal women should receive LHRH agonist during therapy. So the ESR1 mutation was detected by PCR analysis, totally target 4 common mutations. So if you see, there are 3 steps in the study. The first step is like baseline enrollment. Nearly they enrolled 1,000 plus patients. So it should be first and already mentioned, it should be AA sensitive. So baseline, initially they'll assess the ESR mutation detection. After that, later, after 1 cycle, they do analysis of ESR mutation again. Later, every other cycle, that's once in 2 months, they'll analyze the ESR mutation. So later, once the patient got detected with the rising ESR mutation, without any synchronous clinical progression, then the randomization will happen. That's a step 2, either to continuation of AA plus palbociclib or fulvestrant plus palbociclib. And the step 3 is whenever patient progressed on AA plus palbociclib clinically, so he can be crossover to fulvestrant plus palbociclib arm. Totally 3 steps are there in this one. The randomization got stratified on time from inclusion to rising ESR mutation detection and presence of visceral metastasis. So if you see the endpoints, the analysis is totally event driven. So ideally 1000 plus like should be in the first step, 200 patients should be in the second step, and totally 120 PFS event should be recorded with for a significant hazard ratio. So the co-primary endpoints are safety as well as investigator assessed PFS, that's in step 2. And secondary endpoints are second PFS, that's in step 3. When the crossover happened, it's a second PFS. And non-hematological grade 3 adverse events. Overall survival, PFS from inclusion to step 1, from step 1 to step 2 or step 3, time to strategy failure, chemotherapy-free survival, and patient-related outcomes. So how the flowchart happened, I already mentioned 1000 plus patients got enrolled, and later 279 patients got detected with the rise in ESR mutation, and later totally 107 patients got excluded because of the events of synchronous progression, or some patients are off the study. Totally 172 patients got randomized to AA plus palbo versus fulvestrant plus palbo. So the time from inclusion to detection of rising ESR mutation in this patient is almost 14.2 months. So the patients did well on AA plus palbociclib for 14.2 months. So all
I'm
the
sorry
characters.
for interviewing. You have 2 minutes to conclude, please.
Oh, sorry. Yeah, sure. So all the baseline characters are very well matched. Beat the age of inclusion, beat a prior adjuvant AA therapy, metastatic sites are time to rising ESR mutation or ECOG status. So if you see the PFS and PFS analysis, so the step 2, there is almost doubling of the PFS by addition of switch over to the fulvestrant plus palbociclib compared to the AA plus palbociclib continuation. So the subgroup analysis, all subgroups, what I mentioned before, the stratified factors, if all subgroups got benefited with the switching over to fulvestrant plus palbociclib than continuation of AA plus palbociclib. So the toxicity, there is no safety signal. There is no significant toxicity difference, like almost both groups did fairly well, and there is no toxic difference at all. And also, if you come to PFS2, which is very important, so we all know after AS, the fulvestrant will be the option to all of us, like if patient is not PIK3 mutation positive. So for patient who got detected with ESR mutation and continued a switch over to fulvestrant plus palbociclib, the PFS is like 6.2 months. But patient who got clinically progressed and later crossover to fulvestrant palbociclib, it is only 3.5 months. So if you see, if you act upon the ESR mutation, it's almost doubling of the PFS is there. So 3.5 versus 6.2. So what are the conclusions? First clinical trial, the Padawan trial is the first clinical trial to demonstrate the clinical utility of ESR mutation monitoring. So the monitoring in the blood allows optimizing the endocrine therapy partner of CDK4/6 inhibitor. Upon ESR1 mutation detection, the median PFS was doubled by switch from AA plus palbo to fulvestrant plus palbo. There is no safety signal, as I mentioned. The observed clinical benefit might be underpinned by the lower burden of ESR mutation cells at fulvestrant initiation. And the clinical benefit should not be cashed up by the standard fulvestrant based second line therapy. I already mentioned like 2 PFS2 as well. So it justified the implementation of Padawan treatment strategy as a valid option in our clinical care from the Monday morning. And also my colleague is going to discuss regarding Emerald trial, that is elastastin. So it opened a new opportunity for cancer care therapy, that is oral SERT, as well as other clinical settings beyond ESR1 mutation. I thank Nikhil sir and other organizers for giving me this opportunity. I'm happy to take any questions or any comments.
Thank you, ma'am. We'll be having the discussion at the end of when the panel discussion starts. Moving on for the next talk, I invite Dr. Rajesh Bolam, Senior Medical Oncologist, Yashoda Hospital, Hyderabad, to deliver his talk. Welcome, sir.
Yeah, I'll request the organizers to upload my slides, please. Yeah, today I will be discussing on a study of samarasalib a first-in-class oral selective inhibitor of CDK7 in combination with fulvestrant in a patients with advanced hormone receptor positive HER2 negative breast cancer. Next slide. Next. So what is the unmet need in the advanced metastatic hormone positive HER2 negative breast cancer? As we know, we do not have the standard guidelines once the patient had progressed over a CDK4 plus AI inhibitors, except for the few things which are available are like mTAR inhibitors, chemotherapy, combination of PIK3CA inhibitor plus fulvestrant. as told by my previous speaker, if you are tracking the ctDNA continuation and changing the partner. But when you see the amount of PFS what they have got is relatively less. So the problems with these type of agents include myelosuppression, neuropathy, skin reaction, pneumonitis, hyperglycemia, and alopecia. Hormone therapy is well tolerated, but the problem is the efficacy is limited post CDK4/6 inhibitors. Next slide. So what do we have the options? What is the newest kid on the block? The new kid on the block is the CDK7 inhibitor, that's samaracycline. It helps in 3 ways. It's a once a daily oral small molecule ATP competitive selective inhibitor of CDK7. And what is the role of CDK7 in mediating the oncogenic effects? It inhibits 3 pathways. 1, the cell cycle through the phosphorylation of other CDKs like CDK4 and CDK6. Second, it inhibits the transcription of oncogenic and anti-apoptotic genes. 3, by inhibiting the signaling and activation of hormone receptor pathways. Next slide. Samaracycline inhibition of ER-positive breast cancer has grown the strongest in the combination. It is both active along with tamoxifen and fulvestrant. Next slide. So this is a phase 1 study wherein which females aged more than 18 years, histologically confirmed metastatic or locally advanced ER-positive, hormone-positive, HER2-negative breast cancer who had a measurable disease without the prior CDK4/6 inhibitor or without a prior fulvestrant or enrolled. The patient should not have received more than 2 lines of endocrine therapy or more than 1 line of chemotherapy. They have been randomized initially they have been started on samaracycline 240 mg once a day along with fulvestrant 500 mg once in 4 weeks. And after a period of time, they have been switched over to samaracycline 360 mg OD. So in this study, they have determined the optimal dosing of samaracycline and fulvestrant. The optimal dose which they have come to a conclusion was 360 mg OD, which have been carried over to carrying the phase 2 trial. The objectives of the study is to, as I said, to determine the dose, and second one to investigate the preliminary signs of any activity and potential biomarkers. We have one of the potential biomarkers for this study, that is P53, that we'll be learning in the next coming slides. What they have analyzed? They have tried to analyze the responses in the terms of ORR and a CBR. Next slide. So if you see the baseline characteristics around the median age of the population is around 60, 31% of the female and 30% of the patient had a measurable disease, and 30% of the patients are hormone positive diseases. And as I said, prior CDK containing therapy have been included in 31% of the patients. Next slide. So what are the different doses which have been studied and different other parameters which have been included in the analysis is: one is presence or absence of liver mets, second is whether the TP53 is wild or mutant, and third is the dose at which the samaracycline was given. From this graph, it is evident that 360 mg is more efficacious than 240 mg, and the patient who do not have the liver metastasis did fairly well. And the majority of the patients who are on continuing study belong to this criteria of 360 mg with no liver metastasis. And the patient who are TP53 wild are more benefited. The biological reason being explained in the next coming slides. If you see the overall CBR at 24 weeks, it is approximately 36%. And who do not have a liver metastasis, it is 55. And the TP53 wild type patients, the CBR at 6 months is 53. Next slide. And if you see the best RECIST response, what we have got around 70% of the patients, 18 out of 25 available patients had a good tumor shrinkage, at least of confirmed PR. Next slide. So if you see the median PFS by TP53 status, in a TP53 wild patient, the median PFS is around 32 weeks, whereas in TP53 mutant, it is 7.9. How is this TP53 relevant with this molecule? Next slide. So we know that the impact of TP53 in the study is greater than that is reported from the other range of therapies, because we do have a preclinical data that by inhibiting the CDK7, we are going to upregulate the p53 pathway, and if by activating the p53, that is by arresting the transcription and by activating the TP53, we can induce the cells to undergo apoptosis and senescence. So this is what the biological basis why this drug is doing fairly well in a TP53 wild patients. Next slide. So if you see the other parameters which have been discussed here is liver metastasis. If you see from the graph, for the patient who had the liver metastasis, if the PFS is around 11 months, whereas the patients who had 11 weeks, sorry, if the patients who do not have the liver metastasis, it is 48 weeks. We know of presence of liver metastasis is a known risk factor for majority of the ER positive patients. The same has been depicted even in this same study. Next slide. So if you see, till now we have seen the efficacy data, that is 360 MT is efficacious, and we have seen it is more efficacious in TP53 wild and without liver metastasis. Now coming to the adverse effect or a safety profile, majority of the times the grade 3, grade 4 side effects are relatively less than 10%, whereas majority of them are grade 1 to grade 3. And apart from other CDK4, the neutropenia or myelosuppression is not a big side effect. The major side effects are GI related, that is nausea and vomiting corresponds to around 80 to 74% of the population. And now they recommend online citrate prophylaxis for all the patients who receive CDK7 inhibitors post this study. Next slide. So what are the conclusions and future directions from this study? We have got a new option post CDK4/6 inhibitors, that is samaracycline plus fulvestrant, and it is previously active in the patients who have already progressed over CDK4/6 inhibitors. Baseline TP53 wild status as per the ctDNA may predict the extended benefit from these patients, and samaracycline will be co-administered with the oral SERDs in the near future with the clinical studies to extend the limited PFS benefit. Samaracycline has been granted the fast track status by the US FDA based on the above mentioned studies. Thank you. Thanks for giving me this opportunity.
Thank you so much, sir. Moving on, I invite Dr. Deepak Kopaka, Consultant Medical Oncologist, CARE Super Specialty Hospital, Hyderabad, to join us for the next talk. Welcome, sir.
Yeah, hi. I would like to thank the organizers for giving me this opportunity, particularly Dr. Nikhil, sir. I request the organizers to please share my slides. In the meantime, I'll be talking today regarding the new role of LSS trend, which is an oral SERD, which is selective estrogen receptor degrader, in patients who progress on endocrine therapy post CDK4/6 treatment. So as Dr. Kripa Bajaj and Dr. Rajesh were illustrating, there is an unmet need for patients who progress on CDK4/6 inhibitors, and currently the best we have is PIK3CA inhibition with alpelisib, and use it routinely in a practice. Now, this briefly regarding how can we go to the next slide? Next slide, please. Next slide. Next slide. Next slide. Next slide. Next slide. Yeah. So as you can see here, the approach treatment in patients with metastatic breast cancer is we either deprive estrogen receptor by aromatase inhibition, where androgen is prevention of androgen conversion to estrogen is done, or we regulate the receptor, the ER alpha receptor. The previous slide. The previous slide. The previous slide. Can we go back to the previous slide? Yeah. Hello, can we go to the previous slide? Fine. Okay. The phase 3 Emerald study enrolled patients with postmenopausal ERPR positive breast cancer patients. We can go to the next slide. Please go to the next slide. Hello, please go to the next slide. Sorry for the lag. Can we go to the next slide? Can we go to the next slide, please? Next slide. Next slide, please. The next slide. Can we go to the next slide? Yeah. Sorry for the disturbance. Yeah, the phase Emerald study in patients with ER positive breast cancer who receive more than one line of endocrine therapy And most of these patients, all patients were supposed to see a CDK4/6 inhibition. Patients were allowed to receive fulvestrant, and patients who were also allowed to receive 1 line of chemotherapy were enrolled in the study. The pre, please. Patients were randomized. Sorry for the disturbance. I'm pretty short of coverage here. Okay, so briefly, the study had PF at 6 months and at 12 months. Can we go to the previous slide? This is important. Yeah, so previous slide, please. Sorry. Can we go to the previous slide, please? I'm sorry for the disturbance, but can we go to the previous slide? Can we previous slide?
Deepak, I think there is some issue with the way I think the presentation. I think it's not syncing up. Can you start with the slide which you want exactly?
Yes.
Because I think we are just going back and forth.
Yeah, I think can we go to the next slide? Can we go to the next slide, sir? Just the next slide. There's some lag on mine. I'm really sorry for that. Some technical issues. Can we go to the slide? Next slide. Next slide, please. Yeah. So yeah, we can hold here. Thank you. So the baseline characteristics showed 70% of the patients had disease, and only 20% patients had bone-only disease. And once we've seen the stop here. Please stop here. Yeah. So now we see the PFS already. We've seen that most patients progress within the first 2 to 3 months after the patients were enrolled on this study. And once we see patients who were predominantly driven by estrogen receptor mediated disease, there was a separation with the patients who were on elacestrant compared to the other hormones. And statistically significant effects was seen, though it was a minimum month improvement in all patients, whereas patients where ESR1 mutation was seen, that is the group of patients where the hormone active, a significant difference was seen in the PFS. That was 3 months versus 7 months versus 1.5 months. And once you see the 6 and the 12-month interval difference, we see that starts starting after the initial 4 months of exposure to LCS. And the curves are continue to separate over time. Next slide. Next slide. Next slide. Next slide. Is there still a lag? I'm sorry.
So we are currently on the safety and summary slide. Is that correct? Is it what you want?
Yeah, yes, sir. I think that should do. Yeah, I think we should do. I'll just brief summarize about overall survival data. The overall survival difference, there was a significant overall survival difference in one subgroup, whereas in the patients who were all comers, the overall survival mark was not statistically significant, and updated overall survival data we are expected to see in the late of 2022 or early 23. Coming to the safety summary, safety data, only 2.5% there was dose withdrawal, and discontinuation was seen in 3%. The drug was more or well tolerated. Thank you, and yeah, we can. And I'm really sorry for the technical difficulties and my English not right.
No
I'm
problem.
really sorry for that, sir.
No problems. No problems. I think we'll consider this study one more time in the moderation. I think we can invite Dr. Senthil to take over the next session.
Yes, sir. I request Dr. Senthil Rajappa, Senior Consultant Medical Oncologist, Basavatarkam Indo-American Cancer Hospital, to join us as a moderator for the next panel discussion we have. I invite our panelists, Dr. Poonam Patil, Consultant Medical Oncologist, Manipal Hospital, Bangalore, Dr. Biswajit Dubashi, Additional Professor Medical Oncology, JIPMER, Dr. MVT Krishna Mohan, Senior Consultant Medical Oncologist, Basavatarakam Indo-American Cancer Hospital, Hyderabad, to join us for the panel discussion. Welcome, sir. Welcome, ma'am.
Thank you, Nikhil. Good evening, everybody. Time to say good night, but we'll quickly go through this panel discussion for the next 20 minutes and then say good night. So thank you, Dr. Poonam, Biswajit, and Krishna for joining this panel discussion. I want all of you to take your position inside the trench, because you look at what's happening from the trench and then tell us on at the end of this panel as to what you will do on Monday morning. So I'm going to ask just a couple of questions on each of these studies that have been discussed in this session. The question will be, are you likely to adopt this on Monday morning? If yes, why? If not, why not? I think these are the questions that we will look at in the next 20 minutes so that we will wind up on time. Okay, so let's start with the Emerald phase 3 study. So this is the study of this oral SERD, which is elacestrant. Okay, I keep finding it difficult to pronounce elacestrant all the time. So this is 477 patients randomized to elacestrant or investigator's choice standard of care. And the co-primary endpoints were PFS in all patients and PFS in ESR1 mutated patients. So let's go to the conclusion slide. Right. So Krishna, if you get elacestrant on Monday morning, will you be ready to use it? Are you convinced about the results of the study?
Yes, sir. So if we get it on Monday morning, if they also get a patient on the same morning. Yes,
okay. I will send you a patient. Don't worry.
So, yes, sir. So I would definitely consider one of these in this situation. If everything holds on well, I would definitely be tempted to use this drug.
Okay, you will be tempted to use this drug. Biswajit, statistically significant results for sure, because the p-value is significant. Is it a clinically significant improvement? Because if you look at the improvement in terms of the PFS, it's 1.9 versus 2.77. That's less than a month's improvement in the PFS. That's for the intent to treat population, though the hazard ratio is reasonably good, 30%. What would you think, Biswajit?
Yeah, for me, this trial is basically that we are getting an additional oral SERD.
Okay.
I'm not sure whether it's really going to be superior to a fulvestrant and completely replace it. But for a long time, we don't have any other SERD, and it's an oral, because fulvestrant giving 5 ml each month sometimes is painful. It's
very good.
That's how I will look at. I will not look at it as superiority or something.
Okay, you're not going to look at it as superiority. You're saying there's another drug, it's oral, so I'm happy to use it if it's available. Great. Dr. Poonam, let me ask you this question. So I've marked these numbers here.
Yeah.
You know, if a patient is progressing on an AI plus a CDK4/6, would you use anastrozole, letrozole, or exemestane in this patient, or would you jump straight away to fulvestrant?
So if the patient has received...
Yeah, just a minute. Or would you do ESR1 and then decide whether your patient goes on an AI or fulvestrant? What would you do?
So first of all, the partner with CDK4/6 inhibitor would have been an AI initially, most of the times.
Correct.
And fulvestrant, these patients have received, some of them have received fulvestrant before they went on to receive elacestrant.
Right.
So I think if I would like to do ESR mutation, and if the ESR is mutated, I would go with fulvestrant. Otherwise, but anyway, I would definitely change from AI to fulvestrant.
Correct. So that's the point. So we would generally not use an AI unless, you know, somebody is got a problem with using the drug because of cost reasons. Otherwise, I can't remember an instance in the recent past, or even, you know, for a few years now, that I have used an AI after a patient has progressed on a hormonal therapy plus AI. So if you look at the arm, that's the investigator's choice arm, there were just over 200 plus patients, and 68 of them, roughly about 30% of them, actually had something that we would not by today's standards call standard of care at all. So that's my problem as far as this randomization is concerned. So I would have loved to see a neat, clean, straightforward randomization between elacestrant and fulvestrant. Doesn't matter, because if you're getting somebody with an ESR1 mutation, then obviously you're not going to use anastrozole, letrozole, exemestane. This is for people who routinely do an ESR1 mutation. I routinely don't do, because after an AI, anyway, the drug of choice is going to be fulvestrant. So for me, that is a problem that I see in this slide. Okay, let's say somebody has an ESR1 mutation, Krishna. Would you use elacestrant or fulvestrant? For me, this conclusion is not backed up by data that was provided, at least in the slides that I had. Results with elacestrant versus fulvestrant were also consistent. I didn't see a forest plot where patients were divided between these two. So, let's say elacestrant versus fulvestrant, when the results are not there, would you say that elacestrant is likely to be superior to fulvestrant based on some preclinical data?
Sendil, can I just make one point?
Yes,
I think,
Vijit, please.
Yeah, I think the study is very cleverly designed, because ideally they should have done a non-inferiority study with the fulvestrant, but the sample size would have gone very high.
Right.
So very cleverly designed so that they get a superiority. So this sample size comes down, and the control arm is a very poorly done control arm where they've tried to include all kinds of AIs with one or few fulvestrant, and that's how they got the superiority matched. So this study, definitely no way you can say that this drug is superior to fulvestrant.
Excellent. Good. You're coming to the the point that I was trying to make. Thanks, Biswajit. So Krishna, any second thoughts again, or you're happy to use elacestrant because we don't know whether it's better than fulvestrant? If it's as good as fulvestrant, then I think it's still okay because it's an oral drug to use it on Monday morning. Krishna, any second thoughts?
So I would still say give some merit or some consideration.
Yeah, you have to give merit because we are discussing it here. At least for that.
So I
think Okay. Agreed. So for people who are listening, so there are problems with the design of this study. In the ESR1 mutation, we would certainly not use an AI again. So a clean randomization in whichever line of therapy between fulvestrant versus elacestrant would have given the results that we would have liked to see, but not necessarily what the company would have liked to see. Biswajit made a very important point that a non-inferiority design would have made a lot of sense, but that's not what it is. So for me, it's not very convincing, though on paper it seems to be a better drug compared to fulvestrant plus the other ones that were listed as standard of care, which, as I mentioned earlier, I don't think is the standard of care. Great. Let's move on to the next one. Krishna, Pada or Poda?
So it's actually, if you look at all the 4 studies which are discussed, this is the only study where these drugs are available in a clinical practice.
Excellent. Something that we can apply. Yes.
The test is not available.
Very good. Okay.
Their drugs are not available here. The test is not available. But yes, on Monday morning, or if this test is available, I don't wait till Monday morning. I'll do it on Saturday morning only. So I'll call those patients who are eligible, and then we'll try to test that thing and put them on this approach.
Okay, so the design is good. It makes a lot of sense. It's actually a good translation science paper, something that we have clearly proven. I think this is probably the first site that we are actually proving that if you chase the circulating tumor DNA and work on it and change therapy, there might be some benefit. I can't think of any other subsite that we have so far been able to prove this. Dr. Poonam, what are your thoughts on this study? Yes.
No, true what Dr. Krishna said.
Right. So whatever, So how does one finally get to a standardized ESR1 mutation circulating tumor DNA test, Dr. Poonam? I think some of these labs are already offering it, isn't it?
I really don't know which one is offering this BESR1 mutation.
Okay.
I think Datar
is offering it on circulating tumor DNA.
Yes,
you're right.
Yes.
Correct.
So I just know about that one lab. I do not know about other labs.
Okay. So Monday morning, ready for this?
Probably yes.
Probably yes. So I think, as Krishna rightly pointed out, this is something that at least looks like what we can follow on Monday morning, assuming, as he rightly said, that the test is available, a standardized test to pick up the ESR mutations that are mentioned on this trial are actually available. Biswajit?
I have 2 points to make on this trial also.
Yes, Biswajit.
So one is that if you see the frequency of doing the testing, they have actually done every first month, I think they've done, and then every 2 months.
Yes.
So it's very serial monitoring, so many tests they need to do. That's
Correct.
number one.
Correct.
Second question is, once the patient has a clinical progression, those patients are removed if simultaneously they find. So when they actually did 1,000 patients, the number of patients who actually went into the randomization is only 100 and 180 patients. I don't remember the exact numbers, but some 10% or 15%.
Right.
And then you have a outcome which is a PFS. We do not even have an OS benefit. So actually, whether you will be monitoring so often to pick up 10% of these patients, and those 10% of the patients you will be changing the therapy to just to get a PFS benefit, I'm not sure whether it's cost effective to do that.
Okay, so cost is always a problem with these molecular tests, but as we do more and more tests, the cost is likely to
do not have an
come.
overall survival. So if you actually fail at that point of time, you could change it to fulvestrant at that point. Also, maybe we are not very sure.
So Biswajit, let's say if I ask you, do you use alpelisib in clinical practice after doing a PIK3CA mutation, Biswajit?
Yeah.
You do it, exactly.
Right.
Very good. So again, the reason why I'm trying to draw a parallel here, Biswajit, is that if you look at the numbers here, roughly about 6 months versus 12 months, a doubling of PFS, the hazard ratio that you're seeing here, all of these are exactly what you get in the SOLAR-1 study. Again, there you don't have an overall survival benefit that is proven, though numerically the overall survival is better for the alpelisib arm. So I think in a situation like endocrine positive metastatic breast cancer, we now know that it is very much possible to prove overall survival, but I think it takes a longer time for overall survival to be clearly shown. And as Kripa rightly mentioned, this is an event-driven analysis. So I think the numbers are okay because you're not looking at a time-bound analysis. It's more an event-driven. So if the events are accruing adequately, then the trial is adequately powered enough to answer that question. So though your points are important, they are valid, I would still think that if you are somebody who wishes to follow, because the other point is, Biswajit, that when they looked at PFS2, they still saw that the arm which had a change based on the circulating tumor DNA did better. So there is some benefit, whether you want to say this is huge benefit or not is a different question.
I would have been happy if there would have been one more arm where they would have looked at those patients who actually progressed and had that, and instead of changing the therapy completely, they could have just changed the partner drug to fulvestrant, and probably seen whether there was really a difference at that point of time. Because this testing every 2 months is slightly difficult.
Okay.
I have a point, sir.
Yes, Krishna.
So if we see, sir, if we look into these trials, so almost many patients who ever had that higher mutation, it occurred only after 12 months.
14 months.
Maybe
right.
in practice, we can do it first after 6 months, and then maybe we can reduce the frequency as we.
Correct. So I think the point is that it is clearly a good translation. So Biswajit's point is well taken. In theory, it is fine to look at a study like that, but in reality, it is not so easy to design and conduct a study like that. In fact, I think if one thing, if not anything else, that the investigators of this study should really be congratulated for what they have done. Look at the number of samples that have actually analyzed, 12,000 samples. Imagine the cost that they would have incurred and so on and so forth. So I think with all the caveats that Biswajit said and Krishna said, the cost that is involved, the frequency at which you want to test, it is still something that we should certainly think of on Saturday evening and try to see if we can follow on Monday morning, I suppose. That's my personal take on at least this study. It's a well-conducted study, which has answered an important question, is what I would think. Dr. Poonam, best destiny, Monday morning, is that what your patients are destined for?
If the drug is available, certainly yes.
Certainly yes. No complaints?
No complaints.
No complaints.
No
Clean
complaints.
sweep. Distinction, yes. I suppose. Excellent. Biswajit, have you ever seen a study with a p-value of 7.8 into 10 to the power of minus 22?
Yeah, that is amazing. So I think the closest.
So I'm going to ask you, what is the meaning of 7.8 into 10 to the power of minus 22?
Closest trial to what the hazard ratio was closest was probably osimertinib in lung cancer. Even that was slightly higher than this hazards. I think it's
the hazard was slightly better. That was 0.17 or 0.18, but the p-value was not.
P-value was not. And also we must understand that the comparator arm is TDM1. It's not like a very ordinary comparator.
Absolutely.
It's TDM1, which is the comparator. So
I think it's a lovely conducted, clean study. No complaints at all. Clearly TDXD takes the cake. It's the winner. No competitor there at this point in time. Krishna, if you get it on Monday morning, would you be happy to use it upfront, Krishna? Because
Monday
the
morning, yes.
response rates, Monday morning, I'm going to give you everything that you want on Monday morning. So 80% response rate, right? 96% of patients have a clinical benefit. In the second line, it's giving you a super, PFS hazard ratio and the absolute numbers. It's just that we don't have a study, as Vamsi clearly pointed out, but doesn't it look so very attractive to push it in the first line?
Actually, I would say not only HER2 3+, we should try it in HER2 2+ also.
Lovely.
The bystander effect, which is there, at least theoretically.
Super point. So HER2 1+ and 2+ are also candidates. It's just that the response rates there are roughly around 35-37%. But Krishna has made a very important point that if you can lay your hands on TDXD, the other set of patients that you should strongly consider for therapy with TDXD is patients who are HER2 1+ and 2+ by immunohistochemistry. So keep that in mind. You should watch that space for more data. Dr. Poonam, this is supposed to be the 2021 approach. Okay, 2022, at least in February, nothing much has changed. So what would your thoughts be on active CNS disease that you should go on tucatinib, trastuzumab, capecitabine rather than trastuzumab, deruxtecan? Would you be tempted to use trastuzumab, deruxtecan rather than tucatinib, trastuzumab, capecitabine? What would your, choose the winner be here? There's no randomized study between the two.
Yeah, honestly, I don't have experience with either.
Okay. But if I give you both on Monday morning. Okay, so I think the reason why this algorithm shows tucatinib, trastuzumab, capecitabine is that it's got more data. Trastuzumab deruxtecan has got just a small number of some 27 or 35 patients. So, and most of these patients have stable brain metastasis. That means they have been radiated or some kind of treatment has been done. And even if they're on steroids, they should be asymptomatic for the brain met. While the beauty of the HER2 CLIMB study is that half of all patients had brain mets and half of all of them had active brain metastasis, which means they were not treated at all for their brain metastasis early. And that's somewhere around 250, 260 patients. So that's a huge number compared to what you have on trastuzumab deruxtecan. And that's exactly why this algorithm here shows tucatinib, trastuzumab, capecitabine as the second line treatment of choice for patients. Please look at that very carefully. For patients who have active CNS disease, that means you have metastasis there that's symptomatic and they have not received radiotherapy or surgery for that brain metastasis. Biswajit, isn't it becoming like alectinib and osimertinib for EGFR positive lung cancer? So will you slowly start avoiding radiotherapy if you can lay your hands on tucatinib or trastuzumab deruxtecan?
Yeah, definitely, I think.
Because the 20% complete response rate, I think, is phenomenal. Though the drug to look for, though I'm just looking at those numbers, lorlatinib in patients with ALK positive lung cancer, though out of context here, produces a 70% complete response rate. So some of these TKIs are simply phenomenal and they're great. So tucatinib, so trastuzumab deruxtecan gets 100 out of 100 marks from all of us. And if you can get it on Monday morning for the appropriate patient, we'll probably use it without.
Maybe we'll be tempted to use it in NACT also.
NACT also, great. Look, Biswajit has become really aggressive with trastuzumab deruxtecan. Point well taken, Biswajit. I think there's a nice study, something like the Catherine, where patients are randomized. If you have residual disease, patients are being randomized to TDXD versus TDM1. I think that will be a study to look for. And I think looking at this, TDXD is likely to win the race is what I think. Okay, so that I think is our last study, samuracyclib. Krishna?
Sir, I think this is a phase 1 study, sir. Basically, it's a phase 1 study, though they have extrapolated or extended it for responses. I would still wait. And samuracyclib, and it has got significant nausea, vomiting in that line of treatment. And I think we have to wait for the final result before we do it on Monday morning.
Okay, not really for Monday morning at this point in time. Biswajit, any excitement looking at these numbers? Do you think P53 will ultimately be a biomarker for benefit, or rather, if P53 is mutant, do you think it's going to be a biomarker for samuracyclib, or you would just say that P53 is prognostic? We cannot really read too much into that Kaplan-Meier showing 32 versus 7 weeks for P53 wild type versus mutant. Biswajit?
Yeah, I think one is that the drug is used after the CDK4/6 inhibitor failure. So that's one point. And I'm not sure whether TP53 mutation they have tried with as a biomarker previously. So very interesting that why did they actually take TP53 here? Was one reason was that CDK7 has something to do with the retinoblastoma protein phosphorylation and something. But why did they not use this for the CDK4/6 inhibitor? I still not very clear why.
So there is a biomarker analysis of those studies, Biswajit. It's, as I said, it looks to be prognostic. All these patients continue to benefit from a combination of CDK4/6 plus whatever your hormonal therapy is. But the numbers are, yeah. Go ahead, Biswajit.
So if you have a TP53 mutated, also the palbociclib and all these drugs do not work. Is that data?
They work, but the PFS that you're getting is lesser compared to if your P53 is wild type. Correct, because it's prognostic. I think it's prognostic across anatomic subsites. If you have a mutant P53, the outcomes are not really good for many of these TKs. For example,
so probably alpelisib will be the drug. Probably in this setting, alpelisib might work and
correct.
Drugs may not work.
Correct. So placing this drug in the sequence of many drugs that you have for patients with ER positive cancer is going to be really difficult. So as you started this discussion, Biswajit, you have to design a very clever study to really put this somewhere in the midst of the many therapies that we have. Poonam madam, what would that clever study be? Is there anything that you can think of? I can't think of anything because you have to push it to the third line, randomizing patients to a drug like this versus capecitabine or something like that. What do you think? Where would you think this would figure in your list?
So I think P53 here would be both prognostic and predictive, probably.
Okay.
And if there is indeed, if this study just proves itself in phase 2 trials as well, then yes, if P53 is wild type, I would consider samuraciclib. And if P53 is mutated, probably I would not consider that.
Okay, great. So you would do a biomarker driven study so that you get some quick answers. And if you were in the company, that would give you, a lead to start marketing this. The FDA has already given fast track approval status. I think you just go to the FDA, they'll give you a fast track, it looks like. Anyway, let's hope that it'll do good for our patients. So Nikhil, 20 minutes done. We're just on time. View from the trenches. For me, day after tomorrow or the Monday will be like any other Monday. We'll all be in the same trench watching all of these. Though, as Krishna, Biswajit and Poonam madam clearly said, the most attractive of all of them seem to be the PADA study. As I was saying, I hope PADA will not end up being PODA. We will be able to get this test done for our patients, a standardized test that is not very cheap. It will be interesting to see if we can do this at a lesser frequency and get access for the test for our patients and then use fulvestrant in the appropriate patients. We will wait for more follow-up from that study to see, as Biswajit rightly said, if there is some survival benefit. Samuraciclib, really far away. We would love trastuzumab deruxtecan, but I think it's going to be beyond the reach of 99.9% of all our patients at this point in time because of the cost. If a biosimilar will come sometime, that will be a great value addition for our patients. And elacestrant, for the reasons that we mentioned, is attractive, but I think the clinical trial data is not that very robust for us to be adopting it on Monday morning, though it's very attractive to have an oral SERD, which makes things easy. You don't have to poke your patients on both sides every month, which is not a pleasant experience to go through. Any other points any one of you want to make from the trench, Poonam madam, Biswajit and Krishna? Or it's time for dinner, your wives and madam has to serve for, has to join her husband at dinner, I suppose. Thank you so much, all the three of you, for being a sport. I enjoyed it. 20 minutes, it quickly passed away. I thought it will be really difficult to drive something at 9 p.m. in the night. Nikhil, thank you so much, and I'll hand it over back to you.
Thank you so much. I really enjoyed the last moderation as usual by Dr. Senthil. It's always been icing on the cake, and probably it's time for all of us to crawl out of the trench and maybe have some dinner and go to bed. But before we do that, I take this opportunity to thank everyone who have been a part of this particular meeting. To all the faculty, all the delegates, and everyone who had contributed for this meeting. The last 2 evenings have been quite phenomenal in terms of gaining knowledge in the breast cancer updates. Also, I also would like to thank my colleague, Dr. Firdaus, who had sportively accepted to be the master the 2 days during this meeting. Thank you so much. Horizon conferences have helped us in setting up this meeting. Thank you so much for that. And you guys have been exceptional. Mr. Tarun, Mr. Arhan, you have been too good. Thank you so much. We had scientific partners who have helped us with stitching up this meeting together. Again, I would like to thank all these pharma sponsors who had helped us with, getting this particular meeting. And I'm sure we will have a lot of things to catch up, as Dr. Sathiraj mentioned, if not next Monday, but many more Mondays. But I think we always look forward to all those uneasy Mondays as we move on to the newer horizons in terms of oncology. So with this, I thank everyone once again, and I'll see you very soon in one of the offline meetings rather than online meetings. Thank you so much.
So thank you so much, Dr. Nikhil. Thanks from the organizing team, my colleague Aram and Subi, and stay safe, stay blessed. Good night from all of us.